Hello, and everyone, and welcome to the first seminar series, Sex Difference in Hypertension, organized by the Mentoring and Training Committee of the International Society of Hypertension, with the support of the Women and Research Committee of the International Society of Hypertension as well. Here in Argentina, it's 4:30 a.m. I am Rodrigo Morano, and I have the privilege to co-chairing this seminar with Dr. Pence Wu. Also, I want you all join me in welcoming to Dr. Murcha Sterkeling. This is the chair of the Women in Research Committee of the International Society of Hypertension. Dr. Sterkeling, thank you for being here.
Yes, hello everyone. Thank you, Rodrigo. Sorry, it's always difficult. Yeah, my name is Musha Steckelings. I'm chair of the Women in Hypertension Research Committee of the International Society of Hypertension. And a warm welcome also from my side and from my committee side to everyone. And many, many thanks to you, Rodrigo. Hope it's okay now. And to Francine and to the whole mentoring and training committee for organizing this webinar and having this exciting program and for involving us. So it's really an honor, and I think the program looks great and it's so important. And I just wanted to say a very few words so that we can get started soon. Just wanted to say that I'm a pharmacologist, so I'm more a basic researcher. And honestly, before I started working for the International Society of Hypertension, I was not so much aware on how important it is to learn more about sex differences in hypertension. So I didn't really care about it. But then when I started to work for also the Women in Hypertension Research Committee, and I was more asked about these things, and one day I had to give a talk in Indonesia about the topic, and I had to really read about it. And then I realized there are no good evidence-based guidelines all over the world. All the important guidelines do not have really data on how to treat women and on any specifics about hypertension in women. And that's of course a result of the whole chain of how knowledge is gained from basic science. So I was part of the problem and not really considering sex differences in basic science. And then of course the lack of enrollment of women in clinical studies, underpowering of clinical studies. And yeah, so we don't have evidence-based information still. And that's why I think this is so important, the webinar, because you are covering this whole spectrum of where we need to generate knowledge to treat men and women better in the future. So thank you very much again. And I'm very much looking forward to it. And I hope you all enjoy. Thanks.
Okay, thank you so much, Dr. Steklins, for your words and for your presence. With that, I have the privilege to introduce Dr. Jane Reckelhoff. Because the time zone is different from UK to USA, she recorded her talk, so let me share with you her presentation. If you have some question, you can email me the email that is in the chat or email directly to her. She will be happy to answer all questions. So.
Good morning. I hope you all are well this morning. I want to thank Dr. Moranen and the organizers for inviting me to come and present to you today. So we know that blood pressure increases in men and women as they age. This is ambulatory blood pressure monitoring. And these are old studies looking at normotensive individuals. And what you can see is that men have higher blood pressures than women do. Not a whole lot, but a little bit higher. And notice that in men between the ages of 30 and 60, their blood pressure increases slightly, but it's not tremendous. Whereas if you look in women between the ages of 40 and 60, they have a significant increase in their blood pressure. And remember that menopause occurs about 51 years of age. So this is a little more recent data. This is prevalence of hypertension by gender in the United States, and this is from the CDC. And what you can see is that between the ages of 45 and 75, blood pressure increases per decade in both men and in women. But notice that by the time after the age of 75, almost 80% of women in the United States are hypertensive compared to about 70 to 72% of men. So it's a serious problem in women in the United States. So what I'm going to try and convince you of today is that sex steroids have a differential effect on blood pressure control depending on the sex of the individual and the age of the individual. And I'm going to show you data that we have collected over the years in spontaneously hypertensive rats, looking at adult and aging animals, androgen supplements in male obese Zucker rats, and then also show you some data looking at androgens in females, a model of polycystic ovary syndrome. So these are data from spontaneously hypertensive rats that we did 20 years ago. And what we found was that males have higher blood pressures than females. If you castrate the males, you attenuate that hypertension. If you ovariectomize the females, it doesn't really do much to their blood pressure. But if you then give the ovariectomized rats testosterone, you can increase their blood pressure to similar levels as in males when you increase their testosterone levels to the same as in the males. When we looked at the role of the renin-angiotensin system in these animals, what we found was that enalapril really blocked the hypertension in all the groups. But notice that, and to the same level in all the groups, but notice in the animals that were ovariectomized, once we blocked the renin-angiotensin system with enalapril, we were no longer able to increase their blood pressure. So putting together all the mechanisms that are responsible for hypertension, excuse me, in male and female SHRs, what you can see is that there are differences between males and females. So we know that androgens play a significant role in the blood pressure in the males. And we know that the melanocortin-4 receptor plays a role, and that's probably the mechanism for the sympathetic nervous system activation. But there's also an effect on the renin-angiotensin system. In females, you don't see this effect of the melanocortin-4 receptor. And so it plays no role in the mechanisms responsible for their sympathetic activation. And what these are, we don't really know. Also notice that in the males, angiotensin 2 activates oxidative stress. And we don't see that oxidative stress plays in the blood pressure of the females, the female SHR. So there are sex differences in the mechanisms of the hypertension in these SHR. And these, remember, are young adult animals. So what happens with aging? Well, if you look at what happens in males between 4 months and 18 months, their blood pressure doesn't really change a whole lot as they age. And perhaps as you notice, the blood pressure is tending to decrease a little bit in these males, and that's probably because their testosterone levels are decreasing as they age. But notice in the females, they have a tendency to increase their blood pressure, just as we saw in the data from women. But notice by the time they get to be 18 months of age, the blood pressures are similar between males and females. So if we look at potential mechanisms, if we first look at the role of the AT1 receptor in the renin-angiotensin system, you can see that in the young females, losartan reduces their blood pressure and to the same level as you see in the old males. Notice that losartan does decrease the blood pressure in the old females, but not to the same level as in the old males, suggesting that their blood pressure may be mediated by things other than the renin-angiotensin system or other than angiotensin 2 in any case. When we looked at endothelin and used the ETA receptor blocker ABT627, we saw no effect in young females, and we saw no effect in old males. And this is consistent with data from Ernesto Schifrin's group from several years ago now, showing that endothelin really doesn't play much of a role in blood pressure control in male SHRs. But notice in the old females, which we call, now this is a postmenopausal hypertension model, there was a drop in their blood pressure of about 10%. And notice the scale over here for their blood pressure. So about a 10% drop in their blood pressure with endothelin receptor antagonist, suggesting endothelin plays a role in the old females, but not in the old males and not in young females. So aging makes a difference. If we then looked at the role that 20 heat would play, and we gave a cytochrome P450-4A inhibitor, what we found was that there was really no effect in the young females given the 1-ABT, but there was a significant, almost 20 millimeter of mercury drop in the blood pressure in the postmenopausal rats that were given the 1-ABT. So just to reiterate the different mechanisms, in the males, in the aging males, we know that the melanocortin-4 receptor plays a role in their blood pressure, and we think that that causes sympathetic activation. But androgens also cause an increase in the renin-angiotensin system, and then that in turn causes an increase in oxidative stress. Well, we know in the aging females, they have an increase in testosterone, but it's nowhere near the levels that are in the male animals. And so we know that there's an increase in sympathetic activation. We know that that can cause an increase in angiotensin 2, but we also know that testosterone can increase the cytochrome P450-4A, which would increase 20 heat in the renal microvasculature. And we also know that in these old females that endothelin plays a role. So it turns out from studies of Rich Roman that angiotensin and endothelin, in addition to the cytochrome P450-4A, can cause an increase in 20 heat. So we think that 20 heat plays a significant role in blood pressure in aging females, and its effects are on the renal microvasculature. So again, with aging, different responses in males and females. So let's switch to androgen deficiency in males. So we know that, so it's been for a long time, there's been a question as to whether androgen deficiency is the cause of cardiovascular disease or it's a consequence of cardiovascular disease. So the questions are, does having low testosterone in men promote chronic disease such as cardiovascular disease? Or do men with chronic diseases such as cardiovascular disease have low levels of testosterone? If you think about this teleologically, you would not want a male who has cardiovascular disease to procreate. So perhaps this is the mechanism by which the testosterone levels are decreased. And we know that there are numerous conditions in which testosterone levels are decreased. Obesity is just one, and that's what I'm going to show you in just a few minutes. Also, type 2 diabetes, cancers, chemotherapy, chronic kidney disease, COPD, osteoporosis, depression, inflammatory disorders. And we were very surprised to find that when we anesthetize our animals and perform surgery, we get a significant, almost 90% drop in their testosterone levels that takes between 12 and 24 hours to recover. So the hypothesis that we tested was that the reduction in plasma testosterone with chronic cardiovascular disease mediates or promotes that disease. And we looked at obesity as a model and used the obese Zucker rats. So we know that obesity, that testosterone is decreased in obese men, and that they receive supplements because of that. So if you notice in the obese Zucker rats, their testosterone levels are about a third of what the testosterone levels are in lean Zucker rats. So we gave testosterone supplements to both lean and obese, and that increased their plasma testosterone levels by 10-fold, both in the leans as well as in the obese. So this is a pharmacological increase in the testosterone, not really a therapeutic increase. We started the testosterone supplements at 22 weeks of age when we knew that they were not hypertensive, and actually Radu Iliescu showed that. And we gave them the drug, we gave them testosterone for 10 weeks. So until they were 32 weeks of age. So the first thing that we were very surprised about was that when we gave the testosterone supplements, really had no effect on the body weight in the lean animals, but caused a significant reduction in the body weight of the obese Zucker rats. And this is about a 200 to 250 gram drop in their body weights. So along with those drops in the body weights, we saw a drop in the plasma leptin, we saw a drop in the plasma insulin, We saw a drop in the plasma cholesterol, and we also saw a drop in the oral glucose tolerance test, the area under the curve. No real effect in the lean animals at all. But despite the fact that we had a nice drop in their body weights and the metabolic parameters, we saw a significant increase in their blood pressure. So these are the obese sugar rats that are treated with testosterone. Their blood pressure is significantly higher than the obese controls. Notice that the lean Zucker rats have no increase in their blood pressure compared to the controls. And there was an age-related increase in the blood pressure in the obese Zucker rats, but again, a further increase in the blood pressure in the obese rats with testosterone. So I'm not going to show you the data, but suffice to say that we believe that there are several mechanisms, just like the Sprague-Dawley, just like the SHRs, by which the blood pressure increases in these animals. So one of the mechanisms is the conversion of testosterone to estradiol. And actually, Rodrigo did these studies. And what he found was that when he gave anastrozole to block the conversion of testosterone to estradiol, there was a significant increase in the blood pressure, suggesting that the conversion of testosterone to estradiol actually prevents some of the hypertension in these obese Zucker rats. We imagine that the renin-angiotensin system plays a role, perhaps the endothelin system plays a role. We know from other people's work, as well as our own, the sympathetic nervous system plays a role. But very interestingly, when we blocked the production of 20-HEAT, we saw that actually reduced the blood pressure. So this would suggest that there is an increase in 20-HEAT with the testosterone in the obese Zucker males, but it's in the renal tubules, so that when we block it, it prevents the reduction in sodium reabsorption that 20-HEAT in the tubules would do. So this is actually a protective mechanism against the hypertension. So what happens with androgens in women? Well, we know from polycystic ovary syndrome is a condition where androgens are increased in women. It's characterized by hyperandrogenemia, oligo or anovulation, and enlarged cystic ovaries. It's the most common endocrine pathology in women and affects about 10% of women. PCOS can occur as early as menarche. And so other conditions that you find in these women are obesity. In the United States in particular, probably 70 to 80% of women are obese. Along with that, they have metabolic syndrome, they have insulin resistance and dyslipidemia. And even if women are lean and have PCOS, they still have insulin resistance. They also have endothelial dysfunction, and they may have an elevated blood pressure, although particularly in the young women, under the age of 20, their blood pressures, while they're elevated, they're still not to the level of being treated for hypertension. So we developed a model of polycystic ovary syndrome that was actually first used by Manaras and colleagues, in which we implanted the animals with dihydrotestosterone pellets. And that increases the DHT levels, the circulating DHT levels, by about threefold. And that's what you would see in a woman who has PCOS. This level of DHT is not enough to downregulate the endogenous synthesis of testosterone and estradiol. So the estradiol levels are similar in the DHT animals as in our placebo untreated animals. And this is also what you would see in women who have PCOS. The interesting thing about giving these females, these Sprague-Dawley females, DHT, was that it caused a significant increase in their food intake. Now, this isn't a lot. It's only about 3 grams a day, but this is sustained throughout their lives, so that by the time they've been on the DHT for about 30 days, there's an increase in the body weight by 15 to 20%. So this is exactly opposite of the effect that we saw in the obese Zucker rats when we gave them testosterone supplements. Along with the increase in body weight in these hyperandrogenic females was an increase in plasma leptin, an increase in plasma insulin, an increase in the area under the curve for the oral glucose tolerance test, and also an increase in plasma cholesterol. Again, exactly opposite of what we saw in the obese Zucker rats that we treated with androgens. But just like in the males, we saw an increase in their blood pressure when they were treated with DHT compared to controls. So maybe this is a rat thing, which is what I have been told in my grants recently, that, oh, this is a rat thing, this doesn't happen in women. Well, it turns out that, yeah, it does. The responses to androgens that we're seeing in our animal models are very similar to what happens in humans. So visceral and subcutaneous fat associations are increased with testosterone in women, decreased with testosterone in men, decreased with estradiol in women, of course, and increased with estradiol in men. This is from the multi-ethnic study of atherosclerosis. And these investigators found that this was independent of race and ethnicity, these changes with the sex steroids. And so what they suggested was that differential effects of sex hormones in men and women may contribute to gender differences in cardiovascular disease. So what are the mechanisms for the increase in blood pressure in the PCOS model? We know that there's sympathetic activation. We know that because adrenergic blockade as well as renal denervation decreases their blood pressure. But unlike in the SHR females, where the blood pressure is not necessarily mediated by such high levels of androgens, we also see that if we block the melanocortin-4 receptor, we decrease their blood pressure, just like we saw in the SHR males. We also know that 20 heat, unlike in the obese Zucker rats, when we block 20 heat, we see a reduction in their blood pressure, suggesting that the 20 heat in the PCOS rat model is in the renal microvasculature. It's not in the renal tubules. And in fact, with the DHT treatment in these females, there's a 10-fold increase in the cytochrome P450-4A2 message. And when we use a model of cytochrome P450-4A2 knockout, then we can't increase the blood pressure anymore with DHT. And these were studies that Carolina Dalmaso did when she was in the lab. So based on the fact that women with PCOS have had a life of what we would consider metabolic syndrome and cardiovascular disease risks, and we know that they have elevated blood pressure, do they have early cardiovascular disease with aging? And if that's the case, does pregnancy make a difference? Does pregnancy history make it worse? So there really is not a whole lot of information in women, PCOS women, about the long-term consequences of pregnancy. So we know that PCOS women have difficulty becoming pregnant, and they may require reproductive assistance in the form of medication as well as in vitro fertilization. But 65 to 70% of PCOS women who want to become pregnant can. Once pregnant, they have similar outcomes as women who do not have PCOS. They do have a tendency to have an increased risk for preeclampsia, gestational diabetes, depending on how their metabolic syndrome is, and their children are born either large or small for gestational age. And then what happens in the long term, when they go through menopause or later, or what happens with menopause, we really don't know. There is some indication that if they have been pregnant, or that PCOS women may go through menopause later than control women. And perhaps if 70% of these women have been pregnant, that may play a role. Otherwise, there's very little data where blood pressure has been measured, certainly not measured with ambulatory blood pressure monitoring or anything like that. So if you look at our hyperandrogenic female rat model, they also have difficulty becoming pregnant. So only 60% of our rats become pregnant, as opposed to 99% of the regular Sprague Dawley rats. Once pregnant, though, there's a similar outcome, the same number of pups, and they are often, and they're born either large or small for gestational age. And that depends on the vendor that we get the animals from. But what happens in the long term, with pregnancy, we don't know. So we tested the hypothesis in our PCOS rats that were pregnant will be at greater risk for cardiovascular disease with aging. And that's because they have been exposed throughout their lives to metabolic syndrome, hypertension as they age. They definitely develop frank hypertension, and then the increase in inflammation that occurs. So we performed these studies in aging PCOS model. They were 9 to 10 months of age, and these were premenopausal. They go through menopause around 12 months of age, so they stop estrus cycling about that time. And then we compared them to 16 to 18 months of age, and they were postmenopausal. And these studies were done by Carolina and Chaitin and Noha in the lab. And so we compared the PCOS model with the controls at these ages, and whether they had been pregnant or not pregnant. So if you look at the effect of pregnancy in the controls, the body weight is not really different. There's also no difference in the body weight at 10 months of age in the hyperandrogenic female rats, the DHT treated rats, whether they've been pregnant or not. If we looked at the body weight then when they're 16 to 18 months of age, there really is no difference. There may be a tendency for the DHT treated that have been pregnant to maybe be a little bit smaller, but it's not consistent with all the animals, whereas there's no difference in the body weights in the control animals. When we measured the fat mass, the lean mass by echo MRI, we find that they're both increased in the DHT treated rats, regardless of whether they have been pregnant or not pregnant, compared to the controls. We know that their plasma insulin levels are increased. We know that their oral glucose tolerance test is increased compared to controls, and it doesn't make any difference whether they have been pregnant or not. So what that data shows is that the metabolic differences that may be present between previously pregnant and virgin rats are not responsible, because there are no differences. It's not responsible for any differences in cardiovascular disease in these animals. Well, what about DHT levels? We need to make sure that at 16 months of age, that the DHT treated rats, regardless of whether they have been not pregnant or whether they've been pregnant, are the same. And you can see here that the DHT levels are the same. So there's no difference in DHT that could explain any differences between previously pregnant and virgin PCOS rats. When we look at the proteinuria in these animals at 10 months and then at 16 months, and this is now only the DHT treated rats, what you can see is that at 16 months, there's an increase in proteinuria in the virgins compared to what they were at 10 months, and also compared to the DHT treated rats that had been pregnant. When we looked at the nitrate excretion, no difference at 10 months of age, but notice there's even a reduction in the nitrite excretion in the virgins at 16 months, whereas there's no difference compared to 10 months in the previously pregnant rats, and significantly higher in the previously pregnant than in the virgins. So you see where I'm going with this. With the blood pressure, when we looked at 10 months of age, and this is a little bit hard to see, but what you can see is that at 10 months of age, there's no difference in the blood pressure in the DHT treated rats, whether they had been previously pregnant or whether they were virgins. And at 16 months of age, the rats who had been previously pregnant have the same blood pressure as those when they were 10 months. But the virgins had a significant increase in their blood pressure compared to the other groups at 16 months of age. So the blood pressure is increasing only in the virgin rats compared to the previously pregnant. So so this is exactly opposite of what we expected. And why is it that we are seeing these differences? So we did real-time PCR. We found there was no difference in renin, angiotensinogen, preproendothelin with a message. We did find that previous pregnancy caused an increase in the message for eNOS as well as ETB receptor, and reduced the expression of both ACE and the ETA receptor. So what we think is that that the hyperandrogenic female virgins have an increase in the vasoconstrictor, renin-angiotensin system that then causes an increase in endothelin. But we also think that there is an effect on intrarenal inflammation, because we found that there's a reduction in the T regulatory cells that are in the kidneys of these animals. That in turn then would affect kidney function, which would increase the blood pressure. But previous pregnancy, for some reason, we believe decreases or upregulates the vasodilator renin-angiotensin system, and also the vasodilator endothelin system. So it's mediated through the ETB receptor. We also know that there's an increase in Tregs in these animals compared to the reduction that we see in the virgins. So there's some mechanism that is playing a role in that, and that together they cause a reduction in the blood pressure. So we know that all these mechanisms play a role in blood pressure control. Sympathetic nervous system, angiotensin, nitric oxide, oxidative stress, endothelin, renal hemodynamics, 20 heat, but there are other effects too: genetics, epigenetics, inflammation, the immune system. And we know that sex steroids can affect many of these systems, although some we don't know. For example, whether estrogens play a role in sodium reabsorption. We know that androgens do, but we don't know anything about estrogens. And whether estrogens can affect these other effects, we don't know. Well, what happens with aging when the sex steroids are changing? Does it still, have an effect? And we don't know the answer to that yet. And then what happens with aging, though, in transgender individuals when their sex steroids are not changing as they age? So we think this is a great time to be studying sex and gender differences in blood pressure control, and I hope you all will agree with me. And I want to thank all of my trainees, without whom this work could not be. They don't let me in the lab. And so they're the ones who have done all this work, and my students and my technicians. I'd like to thank NIH and American Heart Association for funding, and thank you very much for your attention.
All right. Thank you, Janie, for your talk. So now I'm going to introduce Dr. St. Peters.
Hello, Rodrigo. Hello, everyone.
Yes.
Good day.
I'm delighted to welcome Dr. St. Peters for your contact. Dr. Peters is an associate professor of the George Institute for Global Health and a senior lecturer, Faculty of Medicine, Imperial College London. She holds a joint appointment as associate professor at the University Medical Center, Utrecht. Using large database, her research focuses on sex difference in the prevention, presentation, management, and outcome of chronic disease, mainly cardiovascular disease and diabetes. Also, her work involves the assessment of disparities in treatment and care provided for cardiovascular disease, both for primary and secondary prevention, and what influence such differences have on subsequent adverse outcomes. Dr. Peters' research has been supported by several prestigious grants and fellowships, including 4 years of strategic skills development fellowship from the UK Medical Research Council in 2017, and 5 years BD fellowship from the Dutch Research Council this year in 2021. She is a World Health Federation emerging leader. She is a specialist chief editor for Sex and Gender Difference in Disease in the Frontiers on Global Women and Health Journal, and associate editor of BMJ Global Health. She is a nucleus member of the Population Science and Public Health section of the European Association of Preventing Cardiology. Dr. Peters, welcome and thank you to be here.
Thank you, Rodrigo. Thanks all for attending this, for organizing this seminar. Thank you all for attending. I'm going to talk about sex differences in hypertension from a population-based level. Sorry for this. Sorry. Okay, so just to take a step back on as to why we need to do a sex-specific research and why we need a sex-disaggregated approach. Well, as already was mentioned, historically, most medical research was done on predominantly male populations, and the results from those studies were assumed to be equally relevant for women. But as we now increasingly know, and as we increasingly see, this is not the case. And just as 3 examples, well, between 1997 and 2000, 10 drugs were withdrawn from the US market by the FDA because of serious side effects. And 8 of those drugs posed greater risks for women as compared with men. We now also know that the classical symptoms for heart disease are different for women and men. And given that the male model is still often used as the reference model, it often means that heart disease is missed in women, which can cause severe delays and also death in women due to cardiovascular disease. And also access to care and quality of care is often not the same for women and men. So we can increase our knowledge about disease and improve health outcomes for both women and men. So this is not only a women's issue, by undertaking sex-disaggregated analysis, and also, of course, by including sufficient numbers of women in scientific studies. So for the remainder of my talk, I'm going to talk about sex differences in cardiovascular disease. And again, just as a bit of a background, we know that men have higher age-specific incidence rates and mortality rates of coronary heart disease. And here I present the mortality rates in the USA for 2000, but not much has changed in terms of the sex difference since then. And because of this persistent age difference, the importance of CVD has been underestimated, and it's thought that women are protected against cardiovascular disease. However, this is not the case because the lifetime risk of cardiovascular disease is similar between the sexes, because about 1/3 of all men and about 1/3 of all women are at the end of their lives dying from cardiovascular disease. There are, however, a couple of differences, and I already mentioned the age difference. Well, the age of the first onset of cardiovascular disease is about 5 to 10 years later in women as compared with men. But as I said, the lifetime risk is similar. And as you can see on the left-hand side, the type of cardiovascular disease that women and men develop is also different. So in the blue line, in the top panel, you see that CHD, so coronary heart disease, is the main cause of cardiovascular disease in men. Whereas for women, it's really stroke that from the age of 70 starts to increase tremendously. And that's causing most of the cardiovascular disease cases amongst them. The huge differences, but at the end of life, cardiovascular disease is really the main killer for both women and men. So for the remainder of my talk, I'm now going to talk about how we can assess sex differences in epidemiological studies. And I'm going to focus on sex differences in the effects of risk factors, both in the context of a single study, but also in the context of a meta-analysis. I'm going to briefly touch upon some new approaches to assess sex differences. And then I'm going to end with some key recommendations. I would really like to encourage you all to read this tutorial by my colleague and mentor, Professor Mark Woodward, who wrote an excellent editorial on how to assess these sex differences. So if you want to have more information and want to read more about the specifics of what I'm going to talk about, please read this paper. It's published in Heart 2019. Okay, so first the example of multiple studies. The reason why we actually initially conducted these pooled analysis of multiple studies is because of the fact that single studies were often too small to reliably detect sex-specific effects and to then also quantify those sex differences. So when we started on this journey of quantifying the sex differences, we had to rely upon what others had done before. So here I'm going to talk about the results from meta-analysis and systematic review that we did on all the published literature on systolic blood pressure and the risk of cardiovascular disease in women as compared with men. And as you can see, we identified data from 124 cohorts, including 1.2 million individuals. And the results are published in Stroke 2013. Well, we conducted a systematic review, and on the left-hand side, you see the Prisma flowchart of our search. But I wanted to highlight a couple of things that are important to keep in mind when doing systematic review, and those are we extracted information on relative risks or hazard ratios relative risks or hazard ratios for women and for men. And the studies also had to provide a measure of variability of those relative risks, such as, for example, standard error or a confidence interval. And importantly, given that age is such an important factor and explains really much of the sex differences in cardiovascular disease rates, all of the studies had to have adjusted their findings at least for age. So for this paper, we ended up with 22 studies that contributed data on 124 cohorts. On this slide, I show the study-specific multiple adjusted relative risks for stroke, separately for women and for men. So on the left-hand side, you see on the top half the results for women for the individual studies, and on the bottom half you see the results for men for each of the individual studies. The diamond represents the summary pooled estimates, again separately for women and for men. And the results are for 10 millimeters mercury increase in systolic blood pressure. So we standardized all the results to an identical unit. So for every 10 millimeters mercury increase in systolic blood pressure, we saw that the risk of stroke was 23% higher among women and 24% higher in men. So very similar associations between systolic blood pressure and stroke risk. However, none of the studies that we included estimated the effect of sex on the systolic blood pressure stroke relationship, other than just by providing p-values for a sex difference, which is not enough if you want to quantify these sex differences. I would like to refer again back to the tutorial that I already mentioned, but by doing some relatively simple transformations and by using software programs like Excel, you can obtain the women to men ratio of relative risks, which I present here, and they show that there is indeed no evidence for a sex difference in the effect of systolic blood pressure on the risk of stroke in women as compared with men. And the same was shown in this paper for coronary heart disease. The limitations of this meta-analysis, but also of the other meta-analysis that we conducted on sex differences and the effects of risk factors on cardiovascular disease, is that well, they were based on published studies, and for that reason, they are heterogeneous in terms of the design of the study, in terms of the analysis, and of course in terms of the underlying populations. For stroke, there was in general no breakdown for major stroke subtypes, so for ischemic and for hemorrhagic stroke, which is of course clinically extremely relevant. We also weren't able to compare between risk factors, and there were also no subgroup analysis available, for example, to see whether the sex differences were different between younger and older individuals, or whether they differed based upon socioeconomic status or based upon education level, which are really clinically important subpopulations. And importantly, none of the previous studies looked at sex differences in absolute rates. So, the reason why this is important is that there are some risk factors where we actually see sex differences in the association between the risk factor and the outcome. And the most classical example there is diabetes, where women have about a 50% greater excess risk of CHD when they have diabetes as compared with men. However, women also, when they have diabetes, still have a lower absolute rate of men, irrespective of the fact that they have diabetes. So in order to place the sex differences and relative risks in a context, you also need to consider the absolute risks. And that's what we did. That's what we've now also done in the single study examples. And here I now will present, and I now will indeed present the hypertension results from two studies that we recently conducted in the UK Biobank study. The first one was again on sex differences in the effects of risk factors on myocardial infarction, and we conducted a similar analysis on sex differences in the association between these major risk factors and the risk of stroke, again in the UK Biobank, and we disaggregated by stroke subtypes. So first, I would like to show the results for hypertension and myocardial infarction. So within the UK Biobank, we not only looked at systolic and diastolic blood pressure, but also categorized people based upon the American Heart Association classification of hypertension, so elevated blood pressure, stage 1 and stage 2 hypertension. And as you can see on the top panel, on the left-hand side for women and right-hand side for men, is that there was indeed this gradual increase in the risk of myocardial infarction associated with higher levels of blood pressure. Similarly for women and for men. When we then took the ratios of hazard ratios, we saw that that elevated blood pressure, but also the stages of hypertension, were more strongly associated with the risk of myocardial infarction in women as compared with men. So what we present here are the women to men ratios of hazard ratio. So all the results pointing towards the right-hand side indicate that women have a greater excess risk. So for example, for stage 2 hypertension, this result can be interpreted as that stage can be interpreted as follows. Stage 2 hypertension is associated with a 47% greater excess risk of myocardial infarction in women as compared with men. These are the results for the sex differences in hazard ratios for stroke subtypes. For ischemic stroke, the results were fairly similar to what I presented a minute ago for myocardial infarction, in that we also found evidence for a greater excess risk of ischemic stroke associated in women as compared with men in the presence of stage 1 and of stage 2 hypertension. For hemorrhagic stroke, we had relatively fewer cases, as you would expect, given that hemorrhagic stroke is less common. But there was also the results also pointed towards a greater excess risk of hemorrhagic stroke in the presence of hypertension in women as compared with men. At present, we don't quite know why these sex differences exist, but that's of course food for future. Food for thought, but also for future research into the mechanisms that underpin these sex differences in the association between hypertension and hemorrhagic and ischemic stroke. I already mentioned that it's also important to place these results in the context of sex differences in absolute rates, because as I indicated, at a given age, men are still more likely than women to get an MI, and that's also shown on this in this figure, where you on the very right-hand side see the overall rates of MI in blue for men and in red for women, and women have indeed about a third the rates of MI as compared with men. However, in the presence of certain risk factors such as hypertension, but also, for example, diabetes, we see that the advantage that women have over men substantially attenuates in the presence of certain risk factors. So in the case of diabetes, which you didn't talk about much today, we see that women do not have only a third the risk, but that but they have half the risk of MI once they have diabetes. So they still have an advantage, but the advantage is not as large as it was in the absence of those risk factors. I would like to. So this is a bit about risk factors and now risk factor associations, and I also would like to talk a little bit about sex differences in treatment and management of hypertension. Because there's something interesting about hypertension as compared with the other main cardiovascular risk factors, and that is that hypertension is the only risk factor where we find consistent evidence of better control in women as compared with men. So on this slide, I show data from about 10,000 people with CHD recruited in Europe, Asia, and in the Middle East. And we looked at sex differences in meeting treatment targets for the main risk factors, and also in lifestyle habits after surviving a CHD. And even though we saw that risk factor management overall was worse in women as compared with men, when you look at hypertension, it was actually considerably better in women as compared with men. Women were 31% more likely than men to meet the blood pressure targets. We also saw that women were considerably less likely to smoke, but that's in part related to the fact that our data came to a great extent from Asia, and women are still much less likely to smoke as compared with men in Asia. But it is peculiar that blood pressure management seems to be better, whereas the control of all the other risk factors such as cholesterol, but also glucose was worse in women. And of course, also really important noticing is that meeting all treatment targets was really rare in both sexes. So only 6% of all women met all treatment targets as compared with 8% of all men. So really something to worry about. So we then also did a study on sex differences in the awareness, treatment, and control of hypertension in China. And what we saw there was again that women overall had greater awareness, were more likely to be treated. And if you considered all participants, were more likely to have control of hypertension. However, as you can also see, the advantage that women have over men attenuates as once we move from awareness to treatment to control. So even though women are more aware, they're not better controlled once they're treated than men. Okay, and I would like to briefly touch upon some novel approaches to assess sex differences. Well, I spoke so far about hypertension, and I demonstrated that women have a 47% greater excess risk of coronary heart disease once they have hypertension as compared with men. But what I didn't show is that we also see consistent sex differences in the association between diabetes and CHD, and the same holds true for smoking. The problem with these associations, however, is that they are associations and not causation, and no proof of causation of sex differences. And a novel way to address the causality of the sex differences is by conducting Mendelian randomization. Mendelian randomization is a novel approach from genetic epidemiology that really has many similarities with a randomized controlled trial. However, the difference is that you do not allocate people to an intervention, but you categorize people based upon their genetic risk score and based upon whether they have certain risk alleles or whether they do not have certain risk alleles. And by conducting this Mendelian randomization separately for women and for men, you can actually estimate the causal association between a certain risk factor and the risk outcome separately for women and for men, and independent of all the confounding factors that observational studies are prone to. We haven't done the Mendelian randomization as yet for hypertension, but we have done it for diabetes. And what we showed there was, again, on the left-hand side, we saw this massive sex difference in the association between diabetes and CHD, which was not at all confirmed in the Mendelian randomization approach, which suggests that the sex difference that we found, that the sex differences that we see in the observational data are not purely explained by sex differences in the impacts of diabetes on CHD risk per se. So there may be other mechanisms that are explaining these findings. It may, for example, be that sex differences in treatment underpin the observational findings, or that there are indeed mechanisms early in the pathway that contribute to the sex differences that are ultimately get together in diabetes. This is again something that needs to be studied further. I've touched briefly upon the presence of sex differences in treatment, especially when it comes to the management of blood cholesterol. On the left-hand side, you indeed see that this is data from the US. That's, well, for a period of about 10 years, women were consistently less likely than men to after a myocardial infarction receive the guideline recommended treatment for MI. And the question is, of course, whether this is a proof of undertreatment or whether this is actually tailored treatment, and whether we actually should update the guidelines so to provide sex-specific recommendations for both sexes. And some evidence for that second hypothesis, so the hypothesis of sex-specific treatment targets, was recently provided by a group that looked at the optimal beta blocker dose in women as compared with men for heart failure. And what they found is that, well, in the blue line for women, sorry, for men, and in the red line for women, that women actually achieve their maximum treatment benefit at a much lower dose, at 60% of the recommended dose. And actually that they didn't get any further benefits once the beta blocker dose went further up, suggesting that there may indeed be sex differences in the optimal treatment for heart failure. And this may, of course, be true for other risk factors as well. All right, I'm coming towards the end of my presentation. I would like to first point you towards the Sex and Gender Equity in Research Guidelines, the SAGE guidelines, as they provide a really good toolkit on how to conduct sex and gender specific research. And in a recent piece in the Lancet, we also provided a really brief checklist on how to optimize and how to embed sex and gender in medical research. So I would all encourage you to have a look at that. To wrap up, this is a list of recommendations for conducting sex differences research in meta-analysis. And the results are, the recommendations I would like to highlight are the second and the third. If you do a meta-analysis on sex differences, you need to ensure that you only include studies that reported results from both sexes. So you cannot include a study that only studied women, because there's no comparison group in that study available, which may then bias your results. And also in the report, you really need to state what the reasons were for inclusion of the studies, and also clearly indicate the number of studies that was excluded based upon the absence of sex disaggregated results, which from my experience is generally, well, the vast majority of studies is excluded for that reason. Also really re-emphasizing the need to do those analyses. Then 8 recommendations for any studies on sex differences. I didn't talk about it much today, but we of course need to distinguish between sex and gender when talking about these issues. So sex is the biological variable, whereas gender deals with behavioral, social, and cultural factors. Even if you have a study that either doesn't find evidence for sex differences or is underpowered to find sex differences, those results should still be reported because they can feed into meta-analysis, such as the one I presented on, and you know, so they can still be valuable for future research. You always need to adjust for age when comparing sex-specific cardiovascular associations. You should also always consider to do the analysis both on the relative and on the absolute scale. I didn't touch upon that, but when analyzing the sex difference, you should also always consider the full interaction model, and by that I mean that you also include sex by confounder interactions, or in other words, sex by covariable interactions, because the impact of confounders on your sex on the association that you're interested in can also differ between the sexes, and that can again bias your results if you do not do that. And finally, unless there is statistical or clinical evidence for sex differences, you should refrain from sex-specific conclusions. And I would like to end there. Thank you very much. I'm happy to answer any questions if there's time.
Thank you, Dr. Peter. Excellent talk. Very excited to be here, just watching your data. It's very exciting for, you know, the people do basic and clinical research, and your presentation, you know, were very lucid. And now it's time to a couple of questions if somebody has.
We have good questions in the chat, Rodrigo.
Okay.
Yeah, I saw something about side effects.
Let me check.
You can read them out.
Do women have
a question
more?
about side effects, or?
Yes.
Okay, where is it again?
So
do women have more frequent side effects of statins and beta blockers?
Statin and beta blockers, yes.
That's well, we're not. The answer is the answer is I don't know, because we don't know. There, women in general experience more side effects, but that's when you look at the clinical trials. That's similar between the placebo and the intervention group. So it's difficult to say whether you know whether those differences are, well, they're unlikely to be due to the effects of the drugs themselves. So the answer is that we should be conducting that research, because trials do not routinely report sex-specific side effects. There may be, however, reasons why there are differences in side effects, and that's related to the fact that women and men have different comorbidities, and we also, of course, know that some drugs interact, and that's once you have more comorbidities, you may also be more likely to experience side effects. So even though the side effects from the drug themselves may not be different, if you give those drugs to people with a different clinical profile, it may of course result in differences. But there's no, the main answer is really that there's no strong evidence for that as yet. Thank you.
Okay, thank you. I have a question. You know, the behavior, the population behavior, you know, the hypertension prevalence is different in different regions, you know, around the world. For example, in America, postmenopausal hypertension is more frequently, you know, the event cardiovascular events compared to the men at the same age. Do you see, you know, the same, you know, prevalence in another regions? For example, in Europe or in Asia, you know, the different, like women are more prevalent in cardiovascular event in postmenopausal hypertension?
That's an excellent question. We see huge differences for body mass index, in the sense that that's much higher in the Asia Pacific region as compared with men, as compared with men. I'm not on top of what the sex differences are in hypertension, so but I would refer to the results from the NCD risk, so from the non-communicable disease risk factors collaboration for the most up-to-date results in that, because I'm not gonna, I don't have them on top of my mind. So it's an excellent question.
Okay, thank you. Another question? All right. Thank you so much, Dr. Peters, to be here.
Thanks, thank you all.
Excellent talk. Okay, now we have a 10-minute break. We will be back in 10 minutes. So thank you so much to be here.
So now I'm going to move on to the next speaker. I've got the pleasure of introducing Professor Kate Denton. She obtained her PhD in 1992 at the Baker Research Institute under the mentorship of Professor Warwick Anderson and Professor Paul Corner. Dr. Denton then worked for 3 years at the National University of Singapore before returning to Australia to take up a position at Monash University. Kate has held continuous funding from the National Health and Medical Research Council of Australia since that time, following success in the fellowships. Currently, Kate is an NHMRC Principal Research Fellow and Head of Cardiovascular Disease Program at the Biomedical Discovery Institute of Monash University. Professor Denton leads the Hypertension Research Group at Monash with the aim of improving cardiovascular health for men and women across their lifespan. She has established an interdisciplinary and translational research program around integrative control of arterial pressure, with a strong emphasis on the contribution of the kidney. Current work aims to, number one, understand the long-term determinant of blood pressure control. Number two, identify the causes of hypertension to enable early disease prevention. And number three, to reduce the devastating effects of end organ damage. Professor Denton has over 140 publications and has received multiple awards, including both the Goldblatt and in 2003 and Harriet Dunstan in 2017 awards from the CHR AHA and the Ish Award for Excellence in Research in Cardiovascular Health and Disease in Women in 2018. It's a pleasure to introduce Professor Denton's talk, and I think we've got it ready here. I think it's a pre-recorded one. Shall we start?
Mute. Can you hear me?
Yes. Oh, hello.
Sorry.
Hello, you are here. Sorry.
I am
No,
here.
it's really confusing. So welcome. It's a pleasure to have you here with us.
Thank you for that nice introduction. And I'm glad it went so long because it took me that long to make my slides work. Thank you.
Dr. Denton.
Hello.
Dr.
How are you?
Denton. You know, we are watching your screen plus the small window. Maybe you need to change the.
No, I don't. I did change it, and I couldn't show. When you say, you mean my bit is, I'm big and my picture is
exactly
small?
Exactly.
Let's see if I can do that then.
Maybe you need to just show this
Stop
the full
sharing.
screen.
And I did. Any better?
Still the same.
It still is the same.
I know. I'm gonna have to go out to preferences.
Oh, because you need to maybe press the button of the presentation. You are
I thought I was.
no, but the small window. Yeah, there are 3 squares there. 4. Yeah, that one. I think so.
Which one?
If there's swap,
I've got it
presented
fixed.
view.
Is this working?
It's still much the same, to be honest, but we can sort of see. So
I know this one I can do. View slideshow. Is that better?
it's not. I can't see anything at the moment. It's just seeing the
Excellent.
whole.
I've managed to sort my
Oh, I'm
screen
sorry.
now that I've, it's my fault. Obviously should have shared, and I'm trying to remember.
Are you working with the 2 monitors? Because maybe
I was,
you need
but I've
to
turned
use...
one off. I've turned
Exactly.
one off.
Yeah.
I have turned it off.
Mhm.
Disconnected it, and so now I am surprised it's not working. Can you see the talk now?
Yeah, now it's better.
Yeah.
Just
And
put
now
in,
I've
Oh, perfect. Yeah, that's
excellent.
Oh, yeah.
perfect.
Who knows
Thank you.
what I've done? Yep, excellent. We're about halfway through now.
Yeah.
Well, thank you for that invitation, and it teaches me that perhaps I should have recorded. At least we can hear it. I've got a big storm going on outside, and I'm waiting to lose connection, let's be honest.
Fingers
So
crossed.
I'm going to talk about sex differences in blood pressure and hypertension over the lifespan, with an emphasis looking at the kidneys, because that's where I work. I am going to start with my acknowledgements, primarily because I would like to have enough time to give due recognition to particularly the members of my team over the years that have done all these studies, who have spent the long hours in the work. And I know Katrina's listening, and she has driven a lot of this work, and also the others that have assisted me along the way, and our funding from the Australian government. And so to start, I would like to look at this diagram, which shows us the sex differences in CVD mortality across a number of decades. We can see that in males, with the advent of antihypertensives and other treatments for cardiovascular disease, we rapidly saw a decline in cardiovascular mortality. This was delayed in women, and it wasn't until the 1990s where there was marked disparity in mortality between men and women was recognised. It's really pleasing to see that once this was recognised, there has been a marked improvement, so that in the last decade, the cardiovascular mortality has fairly equalised in men and women. I think what this data also shows, though, is disturbingly that the rates are increasing again. This just looks at is a complicated diagram, but each graph shows the same thing. But what it is showing you is that hypertension is one of the main risk factors for cardiovascular disease, and that it is highly prevalent. And it doesn't matter what country that you look at, it is a major risk factor for cardiovascular disease. And if we look at the US data, mostly because it's plotted in the most simplest way, you can see that risk in younger women is, or prevalence is lower, but as they age, it increases. And this is again true across all the different populations. Women, as they age, hypertension becomes more prevalent. So my talk's going to look at blood pressure across the lifespan, and look at the rhythm in blood pressure to a large extent, looking both at the short-term effects. So I keep putting my elbow on the keyboard, looking at the short-term effects in terms of heartbeat, looking at how over longer we see a change in blood pressure with respiration, we see circadian changes, and we see effects over the years, over the whole lifespan, with blood pressure being low when you're born, increasing quite dramatically during the first years of life, plateauing for quite a long time, and then increasing in later ages. This is affected, at least in women, by the estrous cycle. And as a basic scientist, I'll point out that the estrous cycle has much shorter rhythm than in humans. What we also know is that many of these systems dampen with age, and that they become less responsive, and that adds to things. So let's first of all just look at the wave form of blood pressure. This waveform carries a lot of information. The upward stroke is an index of contractility, the change in pressure over time. The area under the curve between the inflection points when the valves open and close is an index of cardiac output. The augmentation pressure past, or the increase in pressure past the first inflection point when the atrial valve closes can be used as an index of arterial stiffness. And finally, the downward slope, or to diastolic pressure, is an index of total peripheral resistance. And there are marked differences in these waveforms in men and women. And this is not my area, but I introduce it because I want to talk about pulse pressure later. But what the data shows us is that if we just look at pulse wave velocity, so how blood pressure is moves down a blood vessel, we can see that with age, as pulse wave velocity increases, demonstrating that arterial stiffness occurs, and that this the trajectories are different in men and women. Women at younger ages have lower arterial stiffness, but increase more steeply with age, so that they surpass men as they get older. Over here we can see, and I don't have the laser pointer on, I've just realized. Over here we can see the effect of BMI on arterial stiffness. And I've chosen this graph to present of relatively new data because what it shows is that BMI has a much greater impact in females than males. And that perhaps disturbingly, and what I'm not going to address, but what I have an interest in, is that obesity seems to affect younger females more, and that obesity may negate some of the protective mechanisms that are present in younger women, and is something that deserves further attention. And so going back to looking at the different rhythms, we know that there's a circadian rhythm in blood pressure. Here we can see quite clearly, and this is data from in mice using radiotelemetry at different ages and in males and females. And so in young mice, we can see that there is a circadian rhythm, and that blood pressure in females is lower than the males. And so circadian rhythm is different. So it is different across the whole circadian cycle. I will point out to this increase in the young females here in red. What we see is this is the period of the day when people enter the laboratory. When the cleaners arrive, you can almost see an uptick in the females' blood pressure. And what we see is a stress response in the females, but not the males. The females are much more responsive to people coming into the room and making noise. This disappears with age. And what we see is that blood pressure in the mice increases with age in both males and females, but it increases more in the females because by 18 months of age, and these animals are no longer estrous cycling, the blood pressure difference has disappeared. And so there is not a difference. And so when you study blood pressure, at what age, what time of the day, what age, will influence the findings. And there are clear differences between males and females. And that's seen across the lifespan in humans. And so arterial pressure is both age and sex dependent. Here we see data in children up to 18 years of age, and we can see that blood pressure diverges at puberty. Blood pressure tends to plateau in females. You've seen this diagram already today, but it's a seminal study which clearly shows that blood pressure is lower in young women, but that it starts to increase from about 30 years of age, and it is much steeper in the increase with age is steeper in women than men. We importantly, from my point of view, and anyone who does animal studies, we see exactly the same patterns in all the models that we use. So here we have a time series in mice where we can see a very similar pattern to humans, where in the young animals, blood pressure is lower when they start, and in this strain of mice, they start to enter reproductive senescence. The first ones start to cease to cycle around 14, 15 months of age, and by 18 months of age, they've all ceased. And so we don't see a significant difference in those stars have all moved, don't see a significant difference by 18 months of age in the mice. We've measured blood pressure in conscious animals in mice, rats, rabbits, sheep, and always resting blood pressure is lower in females. My work has concentrated on the renin-angiotensin system, so I make no apologies that when I'm looking at the mechanisms and describing the mechanisms now, I'm going to focus on the AT2 receptor, which in the renin-angiotensin system has actions that promote the loss of sodium, cause vasodilation, are anti-proliferative and anti-inflammatory, which all can contribute to a reduction in blood pressure. And we've been looking at the role of this receptor in male-female sex differences in blood pressure. And so for me, it depends on how you ask, how you ask and what question you ask as to whether you will find a difference when you look at males and females. If I show you this data where I've looked at the effect of angiotensin II infusion in mice, I will show you the responses are identical over days using telemetry, and the response to angiotensin II is the same in males and females. However, it's about what range of dose you're looking at. 1,000 nanograms per kilogram of Ang2 is a high dose industrial, and it's about the maximum increase in blood pressure you can induce short term with angiotensin II. Whereas if you use a lower dose, you can see that blood pressure in males and females diverge, and there's a really distinct difference in blood pressure, with females having a lower pressure response than males in these animals at 3 months of age in young animals. And so that's the model that we've used to look at the effects of the AT2 receptor on blood pressure. And so here, these are studies where we've measured blood pressure in mice, in young and aged animals. In males, when you infuse angiotensin II, blood pressure at this dose, blood pressure increases and remains increased, and increases by 20-30 millimeters mercury. Whereas in the same age females, and in the males, if you have in knockout AT2 knockout mice, there is no effect on blood pressure in this strain in the response to angiotensin II. The AT2 receptor is not modulating blood pressure in males. Whereas in females, we see here is our wild type. The response to the same dose of angiotensin II is markedly attenuated. But that in the absence of the AT2 receptor, now the response is almost identical to the, or at least very similar to what we see in the males. The AT2 receptor in female mice buffers the blood pressure response to angiotensin II. What we also showed was that in aged animals, that when you increase blood pressure, in age blood pressure, the response to angiotensin II now is identical in the knockout and the AT2 receptor mice and knockout mice, showing that in the aged animals, there is no longer any protective effect of the AT2 receptor on blood pressure. We went on to look at the effect of estrogen in this effects of estrogen on this model. And here we see in a more condensed form, in young animals or adult animals, we see a modest increase in blood pressure to angiotensin II. In the aged animals, as I've just shown you, we see an enhanced response. If we give an AT2 receptor blocker now, we see no change in blood pressure. If we give these animals estrogen, it does not affect baseline blood pressure. But when we infuse angiotensin II, we see a reduced response to angiotensin II again, similar to the adult animals, and that when we block the AT2 receptor in these animals, we see that the response is enhanced, indicating that estrogen replacement in the aged mice has restored the ability to buffer the increase in blood pressure response to Ang2 that is being mediated by the AT2 receptor. And so what this suggests, at least in mice, is that the AT2 receptor plays an important role in the regulation of blood pressure and may be an adjunct in terms of treating hypertension. But my interest, as I said, is in the kidney and how it contributes to the control of blood pressure. The kidney plays an important role predominant role in the regulation of blood pressure because it matches fluid output to fluid intake and therefore controls blood volume, which controls blood pressure. And this is the circle where the kidney, by controlling how much salt and water is reabsorbed, controls blood volume, which increases or influences filling pressures of the heart, which changes cardiac output, which can then change arterial pressure and perfusion of the kidneys, tissues in general. What we know is that these relationships are not the same. They're similar, but not the same in men and women. And that these are affected by age, hormones, and are disease dependent to a large extent. And so I alluded at the beginning of this talk that changes in pulse pressure were important for end organ damage. And that's because the capillaries are fragile and do not respond well to abnormally high pressures or increases in pulse pressure within the capillary beds. So I've spent a lot of my life doing renal micropuncture studies, and this is a picture of a surface of a kidney. Looking down a microscope, you can just make out the tubules, and here is the glomerulus with a pipette introduced into the glomerulus, and it's squirted blue dye into that glomerulus and Bowman's space, and you can see the proximal tubule lighting up. And I have, in rabbits that have glomeruli on the surface of the kidney, measured glomerular pressure directly. And in the blue trace over here, we can see what blood pressure looks like in the glomerulus, and it averages about 40 millimeters of mercury with a pulse pressure of 5 millimeters of mercury, with that blood pressure being, normal blood pressure being 75 millimeters of mercury normotensive. But in a hypertensive model in these rabbits where blood pressure is increased, we see that glomerular pressure increases. And not only does pressure increase, the pulse increases. And so this puts increased stress and strain on those capillaries, which will trigger mechanisms, increased oxidative stress, increased matrix production, and scarring of the glomerulus until you gradually will cause damage to lose that nephron from functioning. I also noted in these studies that in the hypertensive animals, there was much greater variability. In normotensive animals, you measure glomerular pressure in multiple glomeruli across the surface. The pressure will be almost identical across every glomerulus. They are all operating at the same pressure. Whereas in the hypertensive kidneys, there is much greater variability. There are some that are high, but there are also ones that are actually low. And I've always assumed, though never proven, that these ones are the ones that are starting to fail. But you definitely see a greater variability in a disease model, and that provokes the initiation of damage within the glomerulus. Normally, the kidney is protected from increases in glomerular pressure, arterial pressure. Arterial pressure changes constantly. Every time you stand up, sit down, run, eat, exercise, it changes. But within the kidney, the blood flow is highly auto-regulated and changes little across arterial pressure, the normal arterial pressure range. And that this is primarily due to adjusting the tone of the afferent arteriole. And within the kidney, there are two mechanisms. There's the myogenic mechanism, so the ability of the smooth muscle to contract when it senses an increase in pressure. And the second mechanism, tubular glomerular feedback, which is a mechanism that senses the flow rate of fluid along the tubule. And so how high glomerular filtration rate is. Glomerular filtration rate, again, is highly autoregulated. What this very precise autoregulatory mechanisms in the kidney allow is a precise regulation of reabsorption of both fluid and solutes. So glomerular filtration rate doesn't change. What changes is normally the reabsorption. By keeping filtration constant, the pressure within the glomerulus is maintaining constant, and we see reabsorption changing. And what we see is that pressure natriuresis is not autoregulated, or the phenomena of pressure natriuresis, which is where the urine flow rate increases with arterial pressure. And so these are the mechanisms that protect the glomerulus from increases in pressure. And we have shown that the AT2 receptor modulates these mechanisms in females. So here we've performed an experiment where we've manipulated renal perfusion pressure at different levels, measured both renal blood flow and GFR in males and in females. And what we see is in the females that the introduction of an AT2 receptor blocker does not affect the relationship, but in females it does, particularly at the lower pressures, suggesting that at lower pressures the AT2 receptor is helping modulate glomerular pressure. We also looked at the blood flow response to AT2 receptor modulation. And here again, in males and females, we've infused angiotensin II. We see in the males as the dose increases, that renal blood flow decreases progressively, but there is no effect of the AT2 receptor blocker. But in females, again, we see that the renal blood flow response to angiotensin II is reduced when you increased when you block the AT2 receptor. So the AT2 was preventing vasoconstriction in the female kidney. And similarly, when we administered compound 21 in the females, and so increased renal blood flow, we saw that the compound 21 could increase renal blood flow in the females significantly, but not in the males, an effect that was blocked by the AT2 receptor blocker. So the AT2 receptor plays a role in modulating kidney function. We also looked at tubular glomerular feedback, and here we can sit looking at as tubular perfusion rate increases, you get a reduction in glomerular pressure, stop flow pressure, and index of glomerular pressure. And that when you infuse in here, we're looking at both in the males, both wild type and knockout animals. And it's easy to see that in the control animals that receive vehicle, the lines are on top of each other. Angiotensin II, when it's infused, the dotted lines shifts the curves to the right. So the response, the system becomes more sensitive, but it's unaffected by the AT2 receptor. Whereas in females, if we look in the vehicle, the solid lines, there's no difference between wild type and knockout, but when you infuse angiotensin 2 into the wild type females, unlike the males, it does not shift this relationship. Whereas when you block the AT2 receptor, the relationship is now shifted. The AT2 receptor buffers tuberoglomerular feedback as well. And this is associated with a markedly higher AT2 receptor expression within the kidney. The increase, and there was a modest effect of angiotensin 2, in fact, to increase that expression. Pressure natriuresis, when we looked at it, was also modulated. So this is the classic study where you change the sodium diet, you increase it from a high to a low sodium diet, and to do that, to excrete that extra sodium, you have to increase arterial pressure, and this is showing that relationship. But what it's also showing is that the relationship is very different in males and females. Females excrete the same load of sodium, but a lower arterial pressure than males. When we looked at the role of the AT2 receptor in this, here we can see this is the wild type females, this is aged females, relationship shifts. It shifts even more in the female males as well. So age affects this relationship. When we knocked in the AT2 receptor knockout, all these, the young and old, young males and females are on top of each other, and there is no effect, and they're no longer any different to the aged females. Pressure natriuresis shifts with both age in both males and females, but it's modulated by the AT2 receptor in females, but not males. And so what I've shown you thus far is that the AT2 receptor plays a significant role in preventing or modulating renal function in response to or in the mechanisms that regulate blood pressure, and that they have in place in females with the AT2 receptor a range of effects in the different mechanisms that control blood pressure, the myogenic or vasodilatory response of the blood vessels, pressure natriuresis, and tuberoglomerular feedback are all influenced by blood pressure. What we see though, what we're really interested though, is affecting the end organ damage that occurs with hypertension. So yes, we see that these effects are modulated, and we are now interested in looking at the age effects of renal damage and the disease effects of renal damage and differences in males and females. And so here I'm showing you a marker for renal cellular senescence, SA beta gal. And what we see here, and it's very clear in the diagrams, is that in aged males, you see a marked accumulation of senescent cells. And in females, you do see an accumulation, but it is much lower, and that's shown over here. And we are currently looking at how the renin-angiotensin system and the AT2 receptor modulate these pathways and prevent, and whether we can prevent the occurrence of these senescent cells. These senescent cells are, once they're formed in response to injury, go into a permanent state of cellular arrest, and they develop a senescence associated phenotype where they release cytokines and chemokines that attract inflammatory cells, that then results in a vicious cycle to continually progress the renal damage. And so we're focusing on whether we can remove these cells to try and prevent the progression of the damage. This accumulation of cells also occurs in a model of hypertension. And here I'm showing you stroke-prone spontaneously hypertensive rats. We chose these animals not because they're stroke prone. In fact, these animals are stroke prone when you feed them a high salt diet. We did not feed them a high salt diet, and we saw no animal stroked throughout the studies. But what these animals also have is a much more elevated blood pressure. Blood pressure in these animals is in the order of systolic blood pressure is at 180 millimeters of mercury. And so the damage occurs, it's a more aggressive model and occurs much earlier. And what we see is that compared to the control group, we see marked fibrosis that is enhanced in the males compared to the females, that even within such a short span as 6 weeks, in the difference in the age groups, we see an acceleration in the males, but not the females, and that there is also marked proteinuria in a risk factor for chronic kidney disease, and increase in cardiovascular risk in general is enhanced in the males, but not in the females. So again, protection, and that this is associated again with differences in cellular senescence within the kidney, where we see an increase, marked senescence in the males, but much less in the females. And this is what we are currently trying to look at to see whether we can modulate the progression of disease by targeting these pathways. And so that brings me to the end of my talk, but to summarize, blood pressure is lower in healthy young women than men, and that there are cardiovascular protective mechanisms. And what I've shown you is only one, where we've looked at the differential regulation of kidney function in males and female animal models, and shown that at least the AT2 receptor is more effective in females than males. And that, but there's differential activation of a range of different vasoactive systems. If you look in the literature, and it's not my work, but the work of many others, if you look at almost any hormone, that there are differences in the responses in between men and women. They affect them differently. One of the most marked examples I've always been taken with is that the effect of estrogen in males, in estrogen aromatase knockout mice. If you knock out estrogen, they become hypertensive. The males become hypertensive and obese. Quite dramatically illustrating that estrogen also plays a significant role in males as well, and that we really do not understand the relative differences in the effect of the sex hormones or all the different other regulatory mechanisms in the regulation of blood pressure. And whilst again, I've spoken about the kidney, there is other groups out there that have looked at the vasculature, the heart and the brain, and there are differential effects there as well. And it depends very much upon what stage of life that you look at, whether you're looking at prepubertal, adult, or into old age affects the responses that you see, and that you need to take that into account when you're studying. We are looking at determining whether we can prolong or reinstate those effects by looking at hormone replacement therapy. Certainly in animal models, estrogen is protective. There's been a lot of controversy about hormone replacement therapy in women, but I think the answers are not all there yet. We have also looked at the effect of relaxin, which might be a better choice. It has less potentially detrimental effects and is very potent antifibrotic, so has lots of advantages. I would also like to touch a little bit on experimental design and say how much age affects your results if you're doing animal work, and that if I'm looking at young animals, I would say that you want to keep your animals within 1 week of age, or you are increasing the variation in your responses. With radiotelemetry, I can detect an age-related increase in blood pressure over a 6-week span in rodent models. And so to have a large age range in your studies is going to affect your results. I think once they get over into old age, you can probably have a greater range because you're in a different thing, but it really affects the results, and it's very important that you consider what you're looking at. I also think that less and less think that studying young animals to look at how disease processes are operating when disease, particularly cardiovascular disease, is predominantly a disease of the aged, that the mechanisms change and that you need to be studying aged animals to be able to really look at those processes. Thank you.
Thank you very much to Professor Denton for that fantastic talk. It's really brought into light the importance of the underlying mechanisms. So thank you. I have a question while other people are thinking of other questions, if that's okay. So you mentioned about the BMI having a greater impact of pulse wave velocity in younger females. I was wondering if there's any data in the AT2 receptor in obese young females?
In human, no. There is some evidence in humans that the AT2 receptor modulates, or at least I will temper that statement, but no, not that I'm aware of. But in animal models, there are groups that study obese models in looking at the AT2 receptor and show that it does is attenuated, and that this is more to do with kidney function that I'm aware of. What I think is that obesity has been shown to affect aldosterone production more in females than males, and I know that the AT2 receptor is extraordinarily highly expressed in the adrenal gland, which controls aldosterone, and there may be a relationship there that we haven't looked at yet. There is so much in the differences in the responses that we haven't looked at.
Yeah, that's great work, so much for us to research into. Thank you. Has anyone got any questions?
Yes, Fancy. There is a question in the chat. So, Doctor, fantastic talk, Professor Denton. Is there any difference in macrophage infiltration in the kidney of females and males models?
Yes, absolutely. There are marked differences. It's not an area. I have done some work in this area, and there is definitely movement. There is more Th2 than Th1 phenotype. That the AT2 receptor is very highly expressed on T regulatory cells, and yes, it definitely does play a role.
I have two questions also. In your models, you describe very well, the AT2 receptor and the mechanism of AT2 receptor. My question is related to the sex steroids. Estrogen or androgen interact with AT2 receptors? So
the AT2 receptor is on the X chromosome and is more highly expressed, and estrogen has been shown in some studies, but not all, to modulate the AT2 receptor expression. In our studies in aged animals, sometimes we see that in the aged animals, expression has gone down, and sometimes we don't. And even though we've gone to 18 months, it may not be long enough. And so that's why we just see, depending on the strain, sometimes we do, sometimes we don't.
Okay, great. Thank you for that answer. And the other question that I have is, I wonder in the obese young women, not always the obese is related with hypertension. There are, normal obese normal blood pressure, obese women and hypertensive obese women. So you have some comment about it?
I suspect it's, as with all things with cardiovascular disease, it's not one factor. I think obesity is increasing your risk. And what I think it may be doing is suppressing some of the mechanisms, and that with age we may, and the greater prevalence of obesity in young women, that we may see, start to see differences, and that it may well be due to the fact that obesity and the adipocytes release factors that are influencing the renin-angiotensin system.
Okay, thank you.
Thank you.
Great, thank you very much. I think we're running slightly behind, so I think we'll come back in 5 minutes rather than 10 minutes, and have a good break.
All right. Our next speaker is Dr. Lucy Chappell. Dr. Lucy Chappell is a professor in obstetrics at King's College London, honorary consultant obstetrician at Guy's and St. Thomas NHS Foundation Trust, and an NIHR senior investigator. She runs a research program investigating prediction and prevention of adverse pregnancy outcomes, particularly in women with pre-existing comorbidities such as chronic hypertension and chronic kidney disease, using randomized controlled trials and observational studies. Dr. Chappell, thank you so much to be here.
Thank you very much, and thank you for that introduction. It's quite an ask to cover pregnancy hypertension in 25 minutes, and I thought a bit about how I would approach it, not necessarily as a sort of standard teaching, but to try and whet the appetite of this much wider sort of multidisciplinary audience. And so what I've aimed to do is just talk about some of where we've made progress in the last few years. And also, I'm also going to talk about some of the unanswered questions to try and get this wider audience to think about where the evidence base in pregnancy is considerably different from the evidence base outside of pregnancy. And so hopefully that will be useful. So, very happy to take questions. And please feel free to post questions as you go, and then we'll come back at the end. So the point of antenatal care is detection of hypertension plays a really key role, because although we're trying to get to a safe, happy mum and baby, we know that it is not always smooth, and that the pregnancy hypertension disorders are a big part of that. Sometimes I wonder what progress we're making, and when I do that, here they are measuring blood pressure and boiling urine in 1914, and Ponce Wu, who's the other obstetrician on this call, hosting, knows that that's what we do in our antenatal clinic today. But it's not all as bad as I make it out to be. There have been real strides in understanding about preeclampsia, but also about the care, so that in the UK, these were data at the point where less than 1 woman in every million dies from preeclampsia, showing us that deaths from preeclampsia should be avoidable. So this preeclampsia has moved from a leading cause of maternal mortality to very much being lower down, and other problems like cardiac disease are now very much more of an issue for pregnant women. But that's not the case around the world. This is years where we have comparable data from the UK, where pregnancy hypertension was responsible for 2.8% of deaths, or even 1% in later years.
It sounds like they're just going to replace everything.
Oh, I think you might need to mute.
Laurie came round today.
I wonder if delegates might just stay on mute so that others can hear. Thanks. And this was compared to 7.4% in the US and 14% on a global basis. So this is the impact of pregnancy hypertension is not equitable across the globe. And you can see from this that maternal mortality rates, which are partly driven by pregnancy hypertension, are very much higher, particularly in sub-Saharan Africa. This is with pregnancy hypertension as a sort of second or third leading cause of death after severe bleeding and pre-existing medical conditions. This is matched by neonatal deaths and is also matched by stillbirth deaths, where pregnancy hypertension is a big cause of both, either due to placental problems and the baby dying before birth, or due to prematurity and the baby dying after birth. So that sounds a bit gloomy, but that we have made some strides, and I'm just going to talk about some of those. This is work by one of my fellows, Fran Conti-Vanston, who looked at our confidential inquiry data, where we collect information on maternal deaths from the 1950s. And what you can see in this red line is maternal death rate from pregnancy hypertension. And what is most notable is that the sharpest drop is between the 1950s and the 1970s. And that was before much of the fancy stuff that we do today. So why is that? It's probably because it's antenatal care itself that makes a difference. And this has got really important implications for other countries around the globe. So in later years, we focused on hypertension management, particularly with prompt management of severe hypertension. And we've also focused on fluid management, doing what we say, we run them dry so that women do not die from pulmonary edema. But let's not forget that the provision of free antenatal care may be a big part of that component. And really blood pressure checks, which seem so basic, may be life-saving, particularly in countries where access to blood pressure machines is still limited. Doing work with global health colleagues, this is an image from Ndola, where this is the high dependency unit. This isn't what my high dependency looks like at St Thomas's, but we need to remember that that provision of care is still highly variable. So through the Cradle programme of projects, we've put blood pressure monitors into countries around the globe and looked at the impact of that, and with upscaling other parts of pregnancy hypertension management. So I'm going to move on to saying, how do we diagnose preeclampsia? Again, you might think it's fairly straightforward in terms of hypertension and proteinuria, but that's been imperfect. I'm in clinic every week. I look after women with pre-existing hypertension and pre-existing proteinuria, and the challenges are numerous in diagnosing it. So this is based on the what started as a two-stage hypothesis for preeclampsia, put forward by Jim Roberts and Chris Redman in the 1990s. And the more recent versions of this two-stage model have evolved, looking at the causes on the left-hand side, which are multifactorial and multi-pathway, into the clinical manifestations of a syndrome. It's not a single disease, and really emphasizing that the angiogenic factors, soluble FLT1 and placental growth factor, are one of the pivotal points of this pathway. So the placental growth factor story is interesting because it's led to a change in clinical practice in the UK and many other countries. And it tells the story of a biomarker being developed along a pipeline. Here's one of the first reports of it in a case control study from 1998 from an American group, and going through a longitudinal cohort study where you can see that in women who go on to get preeclampsia, they have a flat profile of placental growth factor, as opposed to this typical inverted U in women who have a healthy pregnancy. So this was shown later by Richard Levine, again showing that in women with established preeclampsia, in the black squares, placental growth factor is low. PLGF, it does what it says on the tin. Low levels are abnormal, high levels show that the placenta is functioning well. So our group went on to do a multi-center cohort diagnostic accuracy study and showed that placental growth factor outperformed all our current tests, either singly or in other data in combination. So this was a cohort of women with suspected preeclampsia, looking at the need for delivery within 14 days. For example, this diagnostic test pulls apart your groups. Now, it's imperfect to change a continuous biomarker into categories, but for the purposes of clinical care, this is often what we use. So in women who have a normal result, they go around 9 weeks until delivery, compared to those with a low result going about 3 weeks until delivery. And in those with placental growth factor less than 12 picograms per mil, 9 days till delivery. So a highly informative potential diagnostic test. So we went on to trial a diagnostic test, and I think this community will know that sometimes we are good at trialing diagnostic tests, but sometimes they fall into practice without a particularly good evidence base. And really, trials of diagnostic tests ask three things. Does the test perform well? And we've shown from a previous cohort study that it does. But you have to ask whether clinicians or women do act differently based on the results. So the pathway of care needs to change in order to make a difference to downstream clinical outcomes. So the test is, at the moment, it's a plasma or a serum-based test using either a point of care, a near patient assay, or for example, a laptop analyzer if it's used through the Roche platform. There's a pathway of care that we agreed to show that you could either continue with usual management or escalate care if the result was abnormal. And in this trial, we showed that using this diagnostic test, when we compared revealed testing to concealed testing, halved the time to diagnosis. And you might say, well, is that important? It may be to the women and the clinicians, and it may change her care pathway. And it also reduced maternal severe morbidity, such that those women who had revealed testing had lower rates of bad things happening, eclampsia, stroke, myocardial infarctions. So with these results in mind, and with the cost effectiveness showing that it was cost saving at around £149 per patient, this has been adopted into NICE guidance, both in the diagnostic test guidance and in the clinical care guidance. And this is now being rolled out across the NHS. There was more publicity on it in the UK press a week or two ago, so that we can actually put an effective test into clinical practice. Next steps are to see whether repeat testing with placental growth factor-based testing through pregnancy is beneficial and again cost effective, and that is work ongoing. So what else has changed over recent years? There has been discussion over when and we should deliver women with preeclampsia, and this mirrors a lot of our quandaries in pregnancy. So particularly for women who are preterm, we ask whether it is better to continue with the pregnancy or better to deliver. Previous research has shown that after 37 weeks, there is no benefit to the woman staying preeclamptic. It isn't great for her heart or her vessels. But we ask ourselves whether it is beneficial for the baby. And earlier work showed that there was no benefit to the baby after 37 weeks. So what are the quandaries? If a woman stays pregnant with preeclampsia, she may have an eclamptic fit, she may have a placental abruption where the placenta shears off the wall of the womb, which is not good for the baby, and you may perpetuate the baby growing in a poor placental functioning environment, which means that you see more growth restriction. Growth restriction in the baby has short-term adverse outcomes, but also is important for the cardiovascular long-term outcomes for that baby. However, there is concern for the delivering babies preterm because of the risk, particularly of respiratory morbidity with transient tachypnea of the newborn and respiratory distress. So we trade off or weigh up the balance of time to go or safe to stay, and really think about which is better. Now, it's not just preeclampsia. You can argue that if you have preterm fetal growth restriction, or if a woman ruptures her membranes early, we face the same dilemma. So this is a common problem in obstetrics. We undertook a timing of delivery trial at 34 to 37 weeks in the Phoenix, which was a multi-centre UK trial. And we showed, not surprisingly, that you improve maternal outcomes, both when you look at maternal morbidity and systolic hypertension, which is a marker for stroke. We are never going to power a trial on maternal stroke because thankfully our very prompt treatment of systolic hypertension in pregnancy now means that stroke is thankfully rare in this group. But we had more perinatal admissions, and we count perinatal admissions because it separates the baby from the mother at a time when that's not ideal. So all of our indicators were in the right direction for the maternal outcomes. We had no neonatal deaths and stillbirths. And I say this because in the global context, this is not true. For example, we're doing this trial in Zambia in India, where about 1 in 5 women with preterm preeclampsia will have a perinatal death whilst they are waiting to be delivered. So this is of particular relevance to other healthcare settings, but we need to get the evidence for that first. Interestingly, for the reasons why babies were admitted is because they were labelled as preterm. So in fact, the other indicators of the baby being sick were no different, such as no difference in respiratory disease, or and certainly no difference or in favour of planned delivery for hypoglycemia. So this remains a trade-off for the women and for the clinicians to consider, because we know that you will make a mother better if you deliver her. That's pretty obvious. And it depends whether the increase in neonatal unit admissions driven by a label of prematurity is good or not, given that there is no difference in neonatal morbidity. So still the balancing act, but now with considerably more information. And does expectant management impact the woman? Well, this is a nice paper from the Rosenblum and Molly Stout's group showing that those who are delivered earlier have less of an impact on cardiovascular morbidity. And that makes sense, because if you get out sooner, you expose the mother's heart and vessels to less of an impact of being preeclamptic. And so we need to think about how we will get longer term information, as this study did, on cardiovascular morbidity. Preeclampsia is not just a pregnancy disorder, it very much has implications for longer term. The shared decision making that I talk about is absolutely crucial. This is some work that we've done to give women information in consultation about the benefits of treatment versus no treatment for high blood pressure, and what our drug choices are currently in labetalol, nifedipine, and methyl-OPA. I'm quite sure that this audience will think those are quite old-fashioned drugs, but we are hampered by getting evidence of safety, which is so crucial for us in pregnancy. So we use this information. These are freely available and endorsed by NICE, our national guideline body, to show that treatment halves the risk of severe hypertension, which is likely to be beneficial, as severe hypertension is associated with adverse outcomes for the baby and for the mother. But these can be difficult decisions and discussions with women, because women often prioritize not taking any treatment in pregnancy, and we have to listen to them and understand their concerns to help them make an informed decision. So what are we still working on? So screening for preeclampsia continues to be a challenge. Here's oh look, this is Ponce's paper, a very helpful paper showing that of the many biomarkers tested, that there's been a lot of work, but it is still complex to understand their efficacy, partly because as researchers, we have not necessarily addressed this in a consistent manner, and there is considerable heterogeneity. But having said that, there is been work, particularly by the Fetal Medicine Foundation, to look at using NICE guidelines, which use a combination of clinical risk factors, compared to a model where you look at clinical risk factors plus others such as mean arterial blood pressure, and a biomarker such as PAP-A or a biomarker such as placental growth factor, with or without the addition of uterine artery Doppler screening, which could be done typically at 12 to 13 weeks and can also be done at 20 weeks. And there's fairly universal acceptance that the multi-factor model will perform better, but the cost effectiveness of this screening approach is still being evaluated. So for a trust that, for example, delivers 6,000 women a year, there is ongoing interest in whether, in how cost effective it is to implement a more complex screening, for example, using biomarkers and ultrasound screening. And certainly for many centres around the globe, that is still, we need to consider how to make these screening tests that use additional modalities accessible to a much wider group of women where the disease burden is highest. So how should we treat hypertension in pregnancy? And this is where our research community really needs to do more work. The total evidence base for treatment versus no treatment is around 3,500 pregnant women. This contrasts markedly to the evidence base for those outside of pregnancy, where 500,000, 1 million individuals and more have been enrolled in antihypertensive studies. So this is for treatment versus no treatment. And the evidence base for the treatments that we use in the UK, labetalol versus nifedipine, there are just 114 women in this trial, which means that we really have an evidence gap. And so we are addressing that through a current trial in the UK of 2,500 women looking at a head-to-head. But there are many other research questions in this area. How do we identify women with preeclampsia most accurately and look at those at risk of adverse outcomes? How do we look at who needs to be admitted, what blood tests should be done, how we should monitor the baby, and when should these women be delivered? So there's plenty of work for our pregnancy hypertension researchers to carry on doing. So I'll come on to how we manage women after birth, because another orphan area work has been the safety of drugs in breastfeeding. And there are a number of groups in the UK, Europe, Australia, and the US who are really interested in ensuring that the safety of drugs in pregnant women and in breastfeeding is addressed. I've just finished as national pregnancy lead for the recovery trial in COVID treatments, where we pushed really hard to get pregnant women included in the mainstream COVID treatment trials and into vaccine trials. And it's reminded me how hard it is to work with sponsors and regulators to make this happen. And the same things happened in pregnancy hypertension, that pregnant women have been at the back of the queue again. So, for example, something as simple as what is the effectiveness and safety of antihypertensive drugs, such as an ACE inhibitor and a calcium channel blocker, which would probably be our two first-line drugs, still needs much further evaluation. The longer-term impact of pregnancy hypertension will again be of particular relevance to this audience. This is work by our group on using electronic health records of over 1 million women, showing that since that the risk of cumulative incidence of first cardiovascular events increases from immediately after pregnancy. This is something that is affecting women in their 30s and 40s, not in their 50s, not just in their 50s, 60s, and 70s. And so this was put together by the NICE guideline committee, showing that if you have hypertension, pregnancy hypertension, you are at higher risk of all subsequent risks, both of recurrent pregnancy hypertension, but also of all adverse cardiovascular events, including ongoing hypertension, stroke, cardiovascular mortality. And there is a real evidence gap in understanding the interventions that would be effective, both in reducing risk of pregnancy hypertension and in long-term cardiovascular disease. Some of the guidelines for screening, such as ESC, include preeclampsia and pregnancy hypertension as a risk factor for subsequent cardiovascular disease. But we now need to move from including them as risk factors to thinking about what interventions for women in their 30s who are postnatal are effective and how do we deliver them? Because the interventions may not look the same as what you deliver to men and women in their 60s and 70s, acknowledging many different aspects of that context. So where are we heading? Well, I think this is, for me, this is a woman who had a healthy live baby after losing 2 babies in previous pregnancies from hypertension. And it's not just that we need to do this in London, we need to do this on a global basis and really understand how to impact maternal deaths and baby prematurity across the globe, because the hit from this disease is considerable. We are making steps, but it's important that we think about how to engage not just the pregnancy community, but a much wider research community in considering what they can do to contribute both from pre-pregnancy, understand what happens in pregnancy, and then really to think about how we tackle the post-pregnancy hit, because these are diseases that really have a very long tail of impact. So I'd welcome thoughts on how we do that. Some of the work I presented is from my fellows in my group, and I hope that I've given you a flavour of how interesting this topic is. I would say that, and also where we have made strides, but also where there is much more work to do. Thank you very much.
Thank you so much, Dr. Chappell. It's an excellent talk. We can do some question right now. Somebody have? Yeah, Dr. Denton.
Hi, I was just wondering, is there differences in sex if of male and female babies? Does it affect the outcomes for both the mother or the child?
That's an interesting question. It's not the overriding factor. There is work that female babies do better when delivered preterm, particularly at the extreme lower end of the 22 to 26, 28 weeks. And I don't think that's well understood, but that relates to preterm birth, not specifically pregnancy hypertension. Interestingly, people view, when I hoik out babies from women with pregnancy hypertension, particularly with growth restriction, they are quite stressed, or they have been stressed in utero, and they often do okay and well to begin with, but the longer term cardiovascular impact of that start in life is less good, and there are other complications such as necrotizing enterocolitis when there's been poor blood supply to the gut that also particularly impact these babies. So it's not my overriding consideration, but I'm sure there are some sex differences, but they're not front of mind, if that makes sense.
Thank you.
Next question.
Can I ask?
Manju Jatla? Yes, please.
Yeah, please. I mean, as we all know that preeclampsia is supposed to be a predisposing factor for long-term cardiovascular diseases. Is there any role for high-risk group of preeclampsia identification as well as a role for aspirin in such a group?
That's interesting. Sorry, and your first bit was identification of that group.
High-risk group who will progress to long-term.
Yeah, I completely agree. And that's an interesting question about aspirin as well. I think we've got to do more work. And one of the reasons I think this has been in the too hard basket for research, because it involves a join up across secondary care and primary care in many healthcare settings. And it's not an easy one to target. I think it probably needs to start with identification, and not just of women with preeclampsia. So women with gestational hypertension, which is pregnancy hypertension without the multi-organ complications, and women with chronic hypertension can all be seen on a sort of spectrum of disease, and they all have a similar adverse cardiovascular hit to varying degrees. Preterm, if you have preeclampsia with a preterm delivery, your risk of cardiovascular mortality is even higher. So it starts with identification, and then we need to consider lifestyle interventions and then therapeutic modifications, whether it's with aspirin or early use of statins. Interesting, some work from the Oxford group, Richard McManus, has showed that if you implement home blood pressure monitoring in the immediate postnatal period, you reduce diastolic blood pressure not just at 6 weeks and 6 months, but recent follow-up has shown that you reduce diastolic blood pressure at 3 years. And we know that diastolic blood pressure impacts on subsequent cardiovascular mortality. So I think it needs this multi-pronged approach to identify them, to think about how we communicate that risk, and then how we offer intervention with both what we know works, but also with some targeted treatment, as you suggest.
Okay, thank you for the answer. I have 2 questions more in the chat.
Yeah.
Martina Rune say, eloquent talk, very thought-provoking. Could you expand on the implication of the revealed versus canceled biomarker testing for preeclampsia?
Yeah.
Is it to inform the mother real decision making around the treatment?
Yeah. That's a really good question. So what we use it for is to determine surveillance. The reason I emphasize that is that it is not to decide, you should not take an abnormal result as indicating delivery, because otherwise all I'll do is cause an epidemic of unnecessary preterm delivery. So it is a diagnostic adjunct in women who come to us with suspected preeclampsia. You could think, I'm not a cardiologist, obviously, but you could think of it like a troponin. It gives you a pathway of care for that woman. So for women with a low or a very low placental growth factor, then they are put on a different pathway of care so that you increase your surveillance, such that you then choose the optimal time for delivery. And what we're really interested in is whether it can also decrease stillbirths or other perinatal deaths in women who are identified as having a much greater risk of preeclampsia. It is better than our current tests. So I would do it both around shared decision making, around surveillance, as well as potential treatment. There is real interest, though, in using it as an entry criteria to target treatments for women developing preeclampsia. And I think that would be really beneficial, so that we are treating those a much more targeted group of patients.
Professor Chapo, may I have a question related to that? You showed us the placental growth factor as a screening test, but I imagine you just said something about it. I imagine it would highly depend on the pre-test probability. So I wondered, because you showed the result in normal women and in women with preeclampsia, but I imagine that in the clinics you would not have, you wouldn't test normal pregnancy. So
yeah, no, that's a really important one.
The efficacy of the test depending on which group you test. How do you select the patients?
Yes, so the data that I've showed is in women with suspected preeclampsia. Now, that is a very pragmatic clinic-based. We, daily in our units, we see women coming in with preeclampsia. So broadly, that is women with hypertension, but without other multi-organ, without a confirmed disease. But you are absolutely right that the test performance or how the test works and should be used relates to your pre-test probability. And so we looked at it in women with suspected small babies, and the test performance is not good. So you need to be aware of the population in which you're using it. There are a couple of other examples. If you do it for routine screening at a fixed time point, such as 28 weeks or 34 weeks or 36 weeks, again, we don't have evidence to support routine screening of women. And if you use it in women with confirmed preeclampsia, reassuringly, around 96-97% of pregnant women with preeclampsia will have an abnormal result, which means that it then, for various reasons, it doesn't perform well to determine need for delivery, because it's already abnormal in a high proportion, and it's not doesn't have further discriminatory potential. So when you read studies around the performance of placental growth factor testing, the first question, as you rightly point out, is in which population is this being used?
Okay, thank you.
Okay, the last question is fantastic talk, Dr. Chappell. There has been some evidence for a role of gut microbial metabolites in prevention of preeclampsia in animal models. I was wondering if you are aware of any work happening in humans.
No, that's an interesting proposal, and I'm not aware in humans. We've moved from a couple of decades ago where there was very little work on prevention of preeclampsia, and to a time when there are many more preventative treatments being considered. Statins in pregnancy have been tried, but don't have their early promise hasn't been fulfilled. Plasmapheresis to remove soluble FLT has been considered. There's some interesting work on metformin, esomeprazole. So one of the challenges of preventing preeclampsia is that we have to think, what are we preventing? Because it's a bit like using the word diabetes. Diabetes, now you're just asking me, what about, is it type 1? You're talking about type 1, type 2, gestational. So we're using one word to describe a really heterogeneous syndrome. And as a research community, we've struggled to pin down what we are trying to, what we are defining. But that looks like interesting work, and there's always space for more both upstream discovery science in this area, and then thinking about how we translate it to the clinical arena.
Okay, thank you so much. And the last question that I have is the biomarkers that you mentioned, I was wondering is there some variation according to the number of the pregnancy? For example, the
Yes.
pH.
Do you mean if it's a twin pregnancy?
Exactly.
Yes.
Twin or several pregnancies, in different time.
Okay, so for women with first or subsequent pregnancies, we don't see any important differences in test performance. In women with twin and multi-fetal pregnancies, it's more complicated because twin pregnancies have got a bigger placenta, broadly speaking. So there is a bit more work to do in understanding, for example, the thresholds that you might use for multi-fetal pregnancies. It's a bit, with placental growth factor, if it's low in a twin pregnancy, it's probably still abnormal. With the other test where you look at soluble FLIT over PLGF, broadly speaking, it still has an application, but the exact thresholds for that group and for another group of women with chronic kidney disease are a little bit more complex.
All right. Thank you so much, Dr. Chappell. It was really, really excellent talk.
Thank you very much.
Well, thank you so much, Lucy. I really enjoyed that talk as well. And it was a very big topic to cover in a short space of time. Next, I'm going to introduce Dr. Anne-Monique Nuit. She is a neonatologist and senior clinician scientist at CHU Saint-Justine, Montreal. Dr. Nuit's research team studies risks of cardiovascular diseases in children and adults who were born preterm. Her translational research program spans from experimental animal work to clinical as well as epidemiological studies. She leads the HAPPY cohort study, Health of Adults Born Preterm Investigation, with Dr. Thaimai Liu, and launched the Quebec Research Network in Perinatal Determinants of Children Health with Dr. Sylvana Cote. She holds the Cirque de Saint-Justine Doha Research Chair. She is currently Professor of Pediatrics and Chief of the Department of Pediatrics at CHU Saint-Justine, Faculty of Medicine, University de Montreal. She is chair of the advisory boards to the CIHR Institute for Human Development, Child and Youth Health. Her research is also funded by CIHR and Heart and Stroke Foundation of Canada. Dr. Nuit was awarded a number of prizes for her work, is actively involved in scientific societies in perinatal as well as adult cardiovascular research and in mentoring both clinicians and scientists.
All right. Can you see the screen?
Yes.
Yeah.
Okay, perfect.
Hello, everyone. I would like to thank Rodrigo Marañón and the organizing committee for this invitation to speak at the ISH training seminar series. My name is Anne-Monique Nuit. I'm a physician researcher and I practice neonatology, which is the care of preterm infants. And it is my great pleasure today to talk to you about my favorite topic, which is the health of my little patients as they grow to become adults after they were born very preterm. Specifically, I will talk to you about cardiovascular risk factors in individuals born preterm. I have no disclosures to declare. I will start with Camille's story. Camille was born at 26 weeks. The normal pregnancy normally is 40 weeks. She was weighing only 920 grams. She had to stay in our neonatal intensive care unit for 3 months. She had chronic lung disease of prematurity, and she had to go home for the first weeks or months with oxygen. However, she grew up to be quite a normal kid with no neurological problem. And after she entered school, she was not followed anymore by any special clinic related to her preterm birth. And here you can see her as she's growing up. Now Camille is finishing her PhD thesis in our laboratory, and she entered med school at another university in Quebec. What is the epidemiology of preterm birth?
According to the WHO in 2014, the global rate of preterm birth in the world is about 10%, 10 to 11%. However, we can see there's quite a bit of changes in percentage of infants born preterm according to which country you're in. So we have about 8% in Canada, 10% in the US, 11% in Brazil, 13% in North Africa, and up to 18% in sub-Saharan countries. In general, it is considered to be related to socioeconomic disparities. And as you can see on this map, even within Canada, we have major differences. Among those 10 infants born preterm, 10% of infants born preterm, 1 in 10 will be born very preterm, which is before 32 weeks. The survival of these preterm born infants has increased markedly since the mid-20th century, from dismal 10 to 20% to now nearly the same rates as term infants, over 90%, even in the very preterm ones born around, we can see on this graph, 26, 28 weeks. Therefore, the challenge so far right now is not as much survival, but disease-free survival, as shown in this recent Nature paper that discussed indeed this very topic. The third trimester, which is the time at which preterm birth occurs, is in fact a critical period of development for many organs. We know, all of us, about the brain and the lung, obviously, but also for the kidneys, the heart, and the overall vasculature. We also know that chronic non-communicable diseases may be determined by early life conditions, and that any disturbances in this early life environment may affect long-term health. We know this is the case, and there's been many studies with low birth weight or intrauterine growth restriction, infants born with intrauterine growth restriction. We also know it is the case with pregnancy complications. Women with preeclampsia, diabetes, their children will have higher risk of cardiovascular diseases. But it is very more relatively recent that the scientific community has been interested on what happens after preterm birth. Well, what we know about blood pressure in children and teenagers who were born preterm is that, in fact, even in those relatively young ages, their blood pressure is a little bit, but significantly higher. Systolic blood pressure is increased by 3 to 4 millimeters of mercury, and diastolic blood pressure by 2 millimeters of mercury. What's interesting is that in these children and teenagers, girls have higher effect of their preterm birth than boys. Their systolic blood pressure is increased around 5/2, whereas boys is 1 to 2 millimeters of mercury systolic over about 2 diastolic. When we reach adulthood, what is the rate of hypertension? Well, indeed, after adjusting for other perinatal and maternal factors, the risk of hypertension is significantly increased in individuals born preterm by 1.2-fold in those born preterm overall, so less than 37 weeks. And when we focus to the extremely preterm ones, those who were born at less than 28 weeks, the risk is increased by 1.8-fold. Interestingly, women and men here are affected similarly. What you have to note in this slide and all the other slides that I will be showing is that the follow-up age finishes in the mid-40s. Why is this? Because simply preterm infants have not been surviving in large number up to the last about generation. So we're only now following up them beyond the 30s and their 40s. Is this associated, this preterm birth associated with adult ischemic heart disease? Well, yes, as well. Another large study that was derived from the well-documented population in Sweden, so only one country, but very interesting data, shows that preterm birth increases the risk of ischemic heart disease. As you can see on this graph, the preterm are in this light orange with the orange line here. And the risk difference seems to be increasing with age. Again, maximal age on this graph is 40 years of age. preterm women have a higher adjusted odds ratio than preterm men. So here women seem to be a bit more affected by their preterm birth regarding ischemic heart disease. What about heart failure? Well, as well, preterm birth increases the risk of heart failure, but this risk difference decreases from birth to the mid-40s. We don't know what will happen after, however. That is something we don't know yet. And here, women and men are affected similarly. Again, this is from large population studies out of Sweden. So overall, we know now that preterm birth is associated with adult chronic conditions. I've mentioned hypertension. It is also the case for type 1, but especially type 2 diabetes, ischemic heart disease, heart failure, kidney disease, and all-cause mortality. What we also know is that preterm adults, again, up to their mid-40s, the prevalence of survival without any major comorbidities will increase with gestational age at birth. So more preterm, less odds of survival without major comorbidities. And it also increases with birth decade. Obviously, the one born in the 90s have less disease or no major comorbidities because also they're younger, or we hope it's because care has improved and they will indeed do better as they age. Let's focus a little bit now about woman health and look at prematurity and pregnancy. Why study pregnancy? Well, we know that pregnancy complications is associated later in life with cardiovascular and metabolic diseases in adulthood. We know that preterm birth, we just saw it, is associated with cardiovascular diseases later in adulthood. So therefore, we ask the question, can preterm birth be associated with pregnancy complications, especially focusing on gestational diabetes, gestational hypertension, preeclampsia, and eclampsia? Pregnancy complications that we studied, we did this study in all women born in the province of Quebec, Canada, from 1976 to 1995, and who delivered between 1987 and 2008. So overall, there were nearly 900,000 women born, and 51,000 were born less than 37 weeks, which is prematurity. Because this group is relatively young, the oldest ones were 32 years of age and the youngest 12 for this study, we were able to study a relatively small, nevertheless consequent number of pregnancies, 7,400, and compared to term. What did we find? Well, we did in this graph, what you see is that the term women are represented by the white bars. The women born themselves between 32 and 36 weeks are in the light blue, and the women born less than 32 weeks are in the dark blue bars. You can see here gestational diabetes, gestational hypertension, preeclampsia, and at least one complication at least once over the pregnancies if they had more than one pregnancy. What we see is that there's really a higher proportion of women born preterm versus term who were diagnosed with pregnancy complications at least once. And this risk increases with lower gestational age at birth. And we reach that nearly 20% of women born less than 32 weeks had at least one complication at least once, compared to nearly 12% of those who were born preterm. We then looked whether these women, beyond the fact that they had some pregnancy complications or independently from their pregnancy complications, were also at risk to deliver preterm themselves. Well, yes. And we also see here a trend. So the more premature themselves were born, the higher their risk of delivering preterm. And here we can see that 14% of women born less than 32 weeks delivered themselves prematurely compared to nearly 10%, which is the population average. When the question now becomes when a woman herself delivers preterm, independently from the fact she was born preterm, so bear with me, is she at higher risk of cardiovascular diseases later in life? Well, it happens that yes. In this study, we see that women who themselves delivered prematurely, we don't know whether they were born preterm or not in this study. So if they delivered prematurely, there's an inverse relationship between the gestational age at which they delivered and their risk of ischemic heart disease up to 40 years after their delivery, which is represented in, again, this large study out of Sweden population data. And the other thing that this study saw was that women who themselves delivered preterm had an increased risk of death up to 40 years later with lower gestational age at their own delivery. So it seems that being born preterm is a risk factor for cardiovascular diseases, but also that delivering preterm is a risk factor for cardiovascular diseases. So prematurity seems to be, whether you deliver preterm or you're born preterm, or maybe both, seems to be an important element in the pathway to cardiovascular diseases that so far we need to understand how and to take it into account when we take history with our patients. So we turn a little bit now to disease, cardiovascular disease characteristic, and try to unravel some pathways and mechanisms. The first question we will ask is, are the pattern of comorbidities similar between those born preterm versus term? The second questions will be, how are the vascular structure and function in those born preterm versus term? And finally, do biomarkers differ between those born preterm versus term? To address these questions with Dr. Liu and myself and our research team, we built the HAPPY cohort study, which stands for Health of Adults Born Preterm Investigation. And we recruited 105 term young adults and 101 preterm born young adults. They were born on average at 27 weeks. They were weighing 920 grams, and we studied them at age 23. You can see pairs. So preterm came with their friend, control, and you can see the happy faces here the day of the study. On average, the preterm were smaller, so were shorter, lighter, but their BMI in our study was the same, and unfortunately, a significant proportion of term and preterm were smoking. What we saw was that indeed there was a high prevalence of cardiovascular risk factor in preterm, but surprisingly, there was no association between factors. This study was carried by Adrien Flao, a postdoctoral student in the lab. So you can see that the preterm here in blue versus the term in dashed green lines have a higher proportion of them have markers of chronic disease and more than one. But surprisingly, to us anyway, there was no significant association between, for example, hypertension and adiposity for the preterm, that you can see here, the blue line stands on the one. So there's no more adiposity in those hypertensive individuals. However, in term, we found the usual association, which is adiposity and hypertension often coexist in an individual. Same with hypertension and glucose intolerance. We were very surprised to see that in preterm, this association was not as systematic as in the term individuals. What about the vascular health of the vascular function and structure of the individuals born preterm? I here present the result from our study, as well as a study from Boardman, from the Oxford group directed by Paul Leeson, who published their studies in 2016 and us in 2020. So what our groups saw was that preterm birth is associated with, in fact, smaller aortic lumen, reduced brachial and carotid distensibility, so we could say a little bit stiffer brachial and carotid arteries, However, when we assess global arterial stiffness, it was not different between term and preterm. And when we assess endothelial function using flow-mediated dilation, it was also not different between term and preterm. So vascular structure seems in the major arteries seems to be a little different, but overall global arterial stiffness or resistance, in fact, seems smaller, and we could not detect changes in the endothelial function. We also examined biomarkers of inflammation and oxidative stress, which we expected to be higher in the group who was born preterm because of their higher rates of hypertension, diabetes, etc. However, there was absolutely no difference in all these biomarkers that I will not list each one of them between our term in green and preterm group. And so here biomarkers of inflammation, and here biomarkers of oxidative stress, urinary 8-isoprostane and redox glutathione from the red cells. So we can see that overall there is a higher risk of cardiovascular diseases and hypertension in individuals born preterm, but the phenotype of their cardiovascular status and associated biomarkers seem to be a little bit different than what we expect to see or what we see usually. So we can examine some, very briefly, some specific pathways to cardiovascular disease. And I will present to you two studies that I think are of interest for this conference. So one, we looked at the kidneys of individuals born preterm, and the other one, we look at erythropoiesis. And I will tell you in a moment why look at these elements. So to start with the kidneys, it is relatively logical to examine the kidneys. First, we all know how important it is in blood pressure regulation and hypertension especially. We also know that nephrogenesis is actively ongoing in the third trimester, and therefore preterm birth could interrupt this important process before it is completed, normally around 36 weeks of gestation. And also upon preterm birth, infants are exposed to medication, which are often nephrotoxic. They are more susceptible to infections, which also can perturb renal growth. It is sometimes difficult to provide to them adequate nutrition. All of this could lead to oligonephropathy and alteration in vasoregulatory peptides. So in the HAPPY cohort, we examined renal function and renal size using ultrasound and reconstituting the renal volume. I told you already that the individuals born preterm had a lower body surface area. The kidney volume of the individual born preterm even was smaller than the term, but even when we adjusted for the body surface area, the kidney volume was smaller. So the kidney volume was smaller than they were smaller. Further, what we saw that there was an inverse correlation between kidney size and blood pressure only in the preterm, but not in the term. So the term here are in green, the preterm are in blue, and the smaller their kidney, the higher was their systolic blood pressure in the 24-hour blood pressure reading that we did. What about renal function? Well, creatinine, which is not a very good marker, but this is what we usually in clinic, was identical between the two groups. However, when we measure glomerular function rate using the fast height equation, in fact, in preterm, it was slightly decreased compared to term. Interestingly, however, when we correct this estimated glomerular filtration rate by the volume of the kidney, which you remember is smaller for the individual born preterm than the term, then in fact what we see is that eGFR per unit of kidney volume is increased in those born preterm, which, might suggest in fact slight hyperfiltration. So if they have less nephron, each nephron has to work a little bit more in order to achieve relatively normal renal function. We also saw very light increased concentration of albumin in the urine, which is far from being pathological, but which nevertheless was significant. So we do have mild signs of reduced renal function in young adults born preterm. However, renal function here did not correlate with blood pressure, but one has to recognize it is relatively mild. We also, in collaboration with Professor Santos in Brazil, we measured plasma renin activity, angiotensin II, and aldosterone, and there was circulating, obviously not in the kidneys, and there was no difference, no evidence for excess stimulation of renin, angiotensin, aldosterone system in these individuals. So in summary, in adults, we have smaller kidneys, reduced total eGFR, but increased eGFR per unit of kidney volume, increased albuminuria, and no evidence of RAS stimulation. What about erythropoiesis? Why study erythropoiesis? Preterm neonates have lower hemoglobin level due to various factors. They have erythropoietin deficiency, we take blood, there's inflammation, and they receive oxygen supplementation, adult blood transfusion. We also know that adults born preterm have chronic respiratory function, and we know that in adults with chronic COPD, they might have higher hemoglobin. Further, hemoglobin levels in adulthood are correlated with blood pressure. These are all studies, but remain very valid. So therefore, our hypothesis was that maybe preterm birth and respiratory function in adulthood could be associated with altered erythropoiesis in adults born preterm and could contribute to their increased blood pressure. And what we found is that indeed hemoglobin is higher in adults born preterm. Here we see male and female, but surprisingly, erythropoietin is absolutely the same between term and preterm for both male and female. So there's no difference there. So therefore, erythropoiesis seems altered in older adults born preterm. So for a given EPO level, hemoglobin levels is 7.2 gram per liter higher in preterm, as you can see on this graph. So either we have excessive hemoglobin production for a given EPO level, or reciprocally, excessive EPO production for a given hemoglobin level in young adults born preterm. What is the answer to this? We don't know. What we did is that we did a mediation analysis to see the importance of hemoglobin on the resulting systolic blood pressure. What we saw is that indeed there's a significant association between preterm birth and higher hemoglobin. We saw it. A significant association between the fact of being born preterm and systolic blood pressure. However, when we mediated the effect of hemoglobin on systolic blood pressure, we saw that 37% of the effect of preterm birth on higher systolic blood pressure is mediated by hemoglobin level, and we lose the significant association between preterm birth and systolic blood pressure when we take into account hemoglobin. Therefore, increased hemoglobin in individuals born preterm significantly participate to the increase in blood pressure, but we don't know the mechanism nor the etiology of this. So in summary, we've seen that preterm birth occurs at a critical time of many organ development. Upon young adulthood, we see that blood pressure is higher. There's some increased stiffness in certain vessels. Hemoglobin is higher, I've not mentioned, but heart rate is higher as well. The burden of disease seems to differ from the traditional metabolic syndrome. The kidneys are smaller. I didn't mention, but there's also insulin resistance, but not much change in lipids. Therefore, my conclusions and key messages to you today is that preterm birth occurs at a critical period of organ development, has an impact on adult health, which is modulated by gestational age at birth. So the more premature the adults were, the greater the chances, the odds of having some chronic conditions. Preterm birth is associated with increases to adult cardiovascular diseases, including hypertension, heart diseases, diabetes, and renal diseases. Preterm birth is associated with pregnancy complications, including diabetes and hypertension. Up to their mid-40s. So as you remember, we don't know beyond that. The impact of prematurity is more important in women versus men for ischemic heart disease and type 2 diabetes, but this was not shown, so there's no difference between men and women for hypertension, heart failure, and stroke. And I am absolutely convinced that we need to use a life course approach to change positively the health trajectory of individuals born preterm. We need to actively prevent, show what is effective in prevention for their specific cardiovascular phenotype that I just briefly presented to you. We need to screen for complications, and I'm sure we need to treat early. But here again, what is the ideal treatment for individuals born preterm with hypertension? This needs also to be tested. So I would like to acknowledge my fantastic research team and especially Dr. Liu, with whom we realized all the studies. We're a co-investigator on all the studies I presented to you, and the great team. You can recognize here Camille, as well as our collaborators and the funding bodies. If you have any questions, I know Rodrigo will email them to me, or you can reach me at that email address. Thank you.
So I think we are now running 10 minutes late. So again, we will have a 5-minute break instead of a 10-minute break. And I'll see you guys back at about 12 o'clock. Hello, everyone. Welcome back. So I'd like to introduce Dr. Judith Zimmerman next. So she's a specialist in cardiology and hypertension. She's in the hypertension department, coordinated doctor at the Cosme Aldrich Hospital in Argentina. She's the head of the Department of Cardiovascular Disease and Women's Health at the hospital, Dr. St. Cosme Aldrich. She's a professor at the University of Pharmacy and Biochemistry, Buenos Aires, of the Babaloro University and the Austro University of Buenos Aires. She's a past president of the Argentina Society of Arterial Hypertension between 2017 to 2019, and the past president of the Committee on Cardiovascular Diseases of Women of the Argentine Federation of Cardiology between 2008 and 2010. Is a member of the Women in Hypertension Research Network at ISH, and her interests are in postmenopausal hypertension and management of women with hypertension. And so I think we've got a recorded presentation, which we are just in the middle of loading up. So if you could just bear with us, that would be great. Thank you.
Please be patient, it's loading, so. All right. Can you see the screen?
Yes, yeah, can see it now.
Yes.
Okay,
Yeah.
perfect. Thank you.
Good morning. I would like to thank Rodrigo Marañón and the International Society Hypertension for invitation to speak to you about the management of hypertension in women. Considering that 1 in 5 women dies due to hypertension, education and prevention must start early on in life. Hypertension may be present in every single state of a woman's life, as you can see in pregnancy, in menopause, in older age, for example. As you can see, in recent years, there are clear signs population aging in Argentina. The statistics show that every 11 minutes, one woman dies from cardiovascular disease, which makes it the leading cause of death in women in Argentina, even surprising all forms of cancer combined. In this recent publication, we can appreciate that the trajectory of blood pressure in both genders. As you can see, blood pressure level in women are lower compared to men until age of 55, 60 years old. However, diastolic blood pressure is always lower in women across the lifespan. However, considering baseline BP level, in this case, 20 years of age, BP increase is steeper in women compared to men. Furthermore, changes in diastolic blood pressure are comparable until the age of 40. These data show that BP increase in women occur since early in life when the extraction levels are low. As you know, the underrepresentation on women continue. In these figures are self-explanatory. Despite the 1993 FDA recommendation, the number of women included in milestone trials like Spring is low. Even the American Hypertension Guideline modify the blood pressure target based on this conclusion. As you can see in different trials, is the same thing about the low representation in women. And the question is should the treatment in women be different? Such as perimenopause, puberty, perimenopause, and postmenopause. I want to underline the difference in women physiology that impact the effectivity of the treatment. Women show lower weight, height, higher proportion and body fat, lower renal function, a smaller heart, and more adverse events effect in general than men. Given all differences, shouldn't we customize treatment in women? And these are the last prevention guidelines on cardiovascular disease from the International Society of Cardiology, still in press, which included one chapter on hypertension in women, which is a good news, I know. As you can see in this slide, the new guidelines cover all the stages of women's life, young women, middle-aged, and elderly women. I would like to share with you some results from the Healthy Hair study done in Argentina. The name in Spanish is the Programa Corazón Sano. The main objective were to investigate the prevalence of hypertension and the association with the risk factor in the city of Villa María in Córdoba to determine the health status perception among women. We also included patient education in terms of good eating habits, exercise, and updating for health care provided. The study included volunteers over 18 years old. Together with my colleague, Dr. Mildred del Sueldo, who is an expert on cardiovascular disease in women, and my friend, we found that women in the 45 and 65 group are more vulnerable because they have a higher cardiovascular and cerebrovascular risk. In this study, as you can see, all the risk factor is very high, and at the present we are replicating this study in different provinces in Argentina. But we were wondering why 45, 65 years old women display worse cardiovascular risk factor than older 65 years old women. But we were wondering why, what is the problem? There are several factors related with the health perception and lifestyle proper from the age, because of wrong health perception, awareness of their own risk, lack of customized therapy, lifestyle, unhealthy diet, sedentarism, work-related stress. This factor will determine that women in this age group are exposed to a large number of risk factors. And this is interesting paper published in the document is differences between the health perception in menopausal women and the actual health status among women. But in this paper, the Linker score we use, we found that in our cohort there was an inverse correlation between hypertension and perception of health status. 40% of women with hypertension reported feeling well, and 10% of them reported feeling very well. This, of course, makes them less aware that they are higher risk. And in this paper, we describe the association between menopause and hypertension and cognitive decline in women, but I will focus on hypertension. In this paper, we describe the association between menopause and hypertension and cognitive decline in women, but if you can see, the prevalence of hypertension increased significantly with age. On the contrary, the percent of women with control hypertension decreased in they become older. What are the potential mechanisms driving this sex difference in cardiovascular risk? I think these four factors, the sex hormone, sympathetic nervous system, the renin-angiotensin and hemodynamic changes are responsible for the gender differences in hypertension. For the treatment point of view, the activation, the renin-angiotensin system reflect vascular and endothelial change. The leading role of nitric oxide decrease and endothelin takes the lead and vasoconstriction prevails. And in addition, there are gender difference of the pharmacodynamic and pharmacokinetic variances, gender specific. Uh, this is it's a good paper of Tariq and collaborated, because it's very important to know about what the treatment is different in the women, and the gender-related difference in antihypertensive treatment. And for many years, what I saw in my clinical practice was motivation to literally go back to basic. Yes, go back to basic. And my hypothesis was renin-angiotensin system inhibition in females improves hypertension by increasing sex hormone level. In my first clinical study, we used enalapril to inhibit renin-angiotensin system in hypertensive and normotensive patients in women with menopause between 1 to 5 years, and we observed that ACE inhibitor improves the symptoms in menopause, such as hot flashes and insomnia, among others. It is interesting to see that estradiol in plasma increase in patients on enalapril, but not increase on calcium channel blockers. This increase in estradiol was found even in normotensive women. Thus, angiotensin II may play a direct role on sex hormone production that we would like to investigate further. In this slide, the figure effect of enalapril on estradiol in Wistar and SHR hypertensive and menopausal rat. The effect of enalapril on the hormones A6 in menopausal rat, Wistar and hypertensive rat. As you can see in the figure 1, a significant increase of estradiol was found in the treated group in Wistar with enalapril compared to the control group. But the figure 2 was not significant in a hypertensive rat. This opened the door to conduct an investigation more with the collaborator of the Professor Shane Reckenholm in Jackson, Mississippi. Thank you, Shane, for your support. It's very important for me. We also wanted to determine the protein expression of alpha and beta estrogen receptor in kidney from normotensive rat. As you can see, ACE upregulation, inhibitor upregulation, alpha and beta receptor in renal cortex, while ACE inhibitor don't have a further effect on the expression of medullary receptors. So there is much more information, but that would be the topic for another presentation. It is more important to bear in mind some difference in relation to young women or women childbearing age or looking for pregnancy and pregnant women. So what? Because some hypertensive drugs have teratogenic effect, but there are options for this group of patients like labetalol, nifedipine, methyl-dopa. This is no teratogenic drugs. This is a specific treatment for these women. Okay, today there is no doubt that in women after menopause, inhibition, the renin-angiotensin system is beneficial in hypertension women. Usually, a combined therapy is necessary, and we can add a calcium antagonist or a diuretic, or usually combine or both drugs. Women experience more adverse events than men, such as cough with inhibition of the renin-angiotensin system, ankle edema with calcium antagonism, and more cramps with diuretic. Therefore, improving the guidelines is a key step to improving cardiovascular health in women. So finally, my take-home message is women are underdiagnosed and undertreated for cardiovascular disease. Prevention is essential to reduce cardiovascular risk and control hypertension. Gynecological checkup tests provide the unique opportunity to perform cardiovascular prevention in young women. The inhibition, the renin-angiotensin system after menopause is beneficial, and definitely more clinical studies are necessary to establish sex-specific treatment. I would like to thank my collaborators and thank you for paying attention, and I will be happy to answer any question. And here you can see the collaborator, different collaborator in the university. Cristina Arranz, Ángeles Costa, Carolina Canifi, and the group of Shane Reckenholz. Thank you very, very much. Lizzie, Yáñez, Julio Sartoni, Radu, and Nieves Claros Martel in Spain, in Madrid. And they are my team in the hospital, the cardiologists, and I work with them every day, and very happy with that. And this is here the work in my country and some Latin American country as part of the Go Red Women program in Argentina. Thank you very, very much.
Well, thank you for that. And if there are any questions, please let us know, and then we can pass on to her.
Okay, our last speaker is Dr. Pensi Wu, my co-chair in this fascinating seminar She is a Bachelor of Medicine and Bachelor in Surgery degrees. She's a MD Res, and she's a member of the Royal College of Obstetrician and Gynecologists. Her current position is Senior Lecturer in Obstetrics, Keele University, United Kingdom. She's Honorary Associate Professor in Obstetrics, National Cheng Kung University in Taiwan, Honorary Consultant Obstetrician and Maternal Fetal Medicine Specialist, University Hospital of North Midlands, and her research interest is hypertensive disorders in pregnancy and adverse pregnancy outcomes and long-term maternal cardiovascular health. Today, Dr. Wu will talk about COVID-19 and cardiovascular women health. Thank you, Dr. Wu.
Thank you, Rodrigo. Can everyone see my slides?
Yes, perfectly.
Yeah, lovely. Yeah. Okay, that's great. So thank you very much for the wonderful introduction and the invitation to do a talk here. I've enjoyed this morning very much. Now I have to say that I'm not an infectious disease specialist nor a cardiologist. I'm just an obstetrician. So what I thought I would do is just to do quite a general overview of COVID-19 and cardiovascular women's health, because I've got a personal interest in this, having had COVID-19 on my birthday just a couple months ago. So outline, I'm going to talk about the epidemiology, the cardiac manifestations, the women's health and pregnancy, and then talk about treatment and anticoagulation, also vaccinations and health disparities. And if we have time, then I will go on and cover post-COVID syndrome and cardiovascular health. That's not so much to do with women's health, it's more general. So epidemiology, this is the state of play as per yesterday from the Johns Hopkins dashboard. So as you can see, the total cases now is a staggering 39 million cases, with total death at 642,000. But the good news is that there's been lots of vaccine doses administered, 370 million doses. And over here, you can see the temporal trend. So this is per weekly cases. So you can see that we've gone past the peak now, even though it seems like we're now sort of heading towards another smaller peak. But what is reassuring is that the weekly death is now much lower than what it was when we were in the highest peak. And over here is just showing that we are administering lots of vaccine doses. So this is the organism SARS-CoV-2. It's in the coronavirus family. It's called corona because of the spike proteins making it look like a crown. Infects mammals and birds, causes 15% of common cold. And we've had previous experience with SARS and MERS, and now in the middle of the COVID-19 pandemic. Key features, we've already talked about the spike protein. And then what it does is that it hooks onto the ACE2 receptors in the host cell, and in particular the ACE2 receptors in the respiratory tract. And then it will transmit person to person when an infected person shares the virus. So we've already talked a lot about ACE2 today, and now just in terms of the COVID-19, you have expression of the ACE2 receptor in lots of tissues, but where we're interested in is the lungs, where it leads to ARDS and respiratory failure, the heart, where it can lead to myocardial infarction, heart failure, myocarditis, arrhythmia, and also effects on vasculature with endothelial dysfunction and vascular inflammation and macrovascular thrombosis, etc. So this is quite a simple slide of the disease course of COVID-19, but I thought it provides a nice overview. So it can incubate in the first 5 days at the pre-symptomatic phase, and then as you get the viral phase, and then what happens is that actually what leads to the more severe disease is the inflammatory response. So as time goes on, most people have mild to moderate illness, and this sort of settles around about 10 days. But those with severe disease could have hospitalization, shortness of breath, ARDS, and ICU admission. So next, we talk about the cardiovascular manifestations. And this is very similar to the time course that we just talked about, but more focused on the cardiovascular side. So again, this is the timeline, day 5, day 10, and then hopefully recovery. So you've got the first the viral phase, and then pulmonary phase, and then the hyperinflammatory response phase. So initially, we've got the innate immune response with the inflammation, and then gradually goes to adaptive immune response with the cells and cytokines. And this is where, so between day 5 onwards, you can have the cardiovascular effects, such as direct ACE2 mediated injury, hypoxia-induced injury, microvascular thrombosis, systemic inflammatory injury, and then towards here, the autoimmune reaction towards the end here. So here is a proposed mechanism of cardiac injury with the clinical sequelae. So you've got the SARS-CoV-2 leading to hyperinflammation, immunopathology affecting the heart, also direct myocardial injury, and through respiratory failure and hypoxemia as well. And then you can lead to biomarkers of injury, so such as asymptomatic troponin elevation, and you can have arrhythmias, ECG changes, acute coronary syndrome, and inflammatory or cardiogenic shock with type 2 myocardial infarction, myocarditis, stress cardiomyopathy, heart failure, and right ventricular dysfunction. And this could be secondary to ARDS, hypoxemia, and pulmonary embolism. And of course, there's the venous thromboembolism and the Kawasaki type syndrome in children. So this is quite a complicated slide, but basically just going into a little bit more depth to what I've just said. So I'm just going to talk about this kind of quite superficially, otherwise we'll be here for ages. So I've got the SARS-CoV-2 here invading the tissue into the lungs, leading to inflammation with the T cells and macrophages causing cytokine storm here, and that can lead to the myocarditis or plaque rupture and ACS here. Also, you have immune activation, again, leading to myocarditis. Another way is through the myocardium, and then I can't see the top of the slide, but I think it's basically to do with plaques, and in the coronary artery, you've got the plaque instability and rupture. Oh yes, so on top here is about microvessels, and it leads to microvascular dysfunction. And then down here, you have a change in the metabolic activity as well. And down here, through the myocardial damage, it can lead to arrhythmia. So, of course, we all know that underlying medical can lead to more severe COVID-19. So this is a slide just in a population showing that the most common comorbidities in COVID-19 include essential hypertension, dyslipidemia, obesity, diabetes, atherosclerosis, etc. And as we just learned this morning in Dr. Brewster's talk, that women with PCOS also have a 50% higher risk of COVID-19. So next, moving on to women's health and pregnancy. So in the initial part of the pandemic, there was a thought that perhaps men are more vulnerable and women are protected. And here's an editorial, opinion piece in Jack Cade's reports, and just talking about some possible reasons for sex differences in COVID-19. Because in women, it's thought that they had a lower mortality case fatality ratio, and it's thought that they had less pre-existing comorbidities. But I would argue that it's probably it's more undiagnosed comorbidities because women don't tend to present to doctors. Also thought that they've got less high-risk behaviors, such as smoking and alcohol use. But I'll go on to talk about women's issues in particular. And biologically, it's thought that they've got a better innate immune response. And as we already talked about, the biological differences with the ACE2 receptors and ACE2 enzyme activities. And because estrogen lowers the ACE2 receptors, therefore the postmenopausal women are at higher risk of severe COVID-19. So now we all know that there are gender inequalities. So actually, I think women are a vulnerable group for COVID-19. So from the economic point of view, they have a greater burden of domestic and care work. They're in jobs where they are more likely to lose their jobs. And as a result, they have reduced financial independence and future prospects. In the healthcare system point of view, there's a lot more women in healthcare, and as a result, they're at a higher risk of exposure from COVID-19. They also have reduced access to vital health services and exclusion from potential treatments in some countries in the world. In terms of health and well-being, there's an increased risk of pregnancy-related death and teen pregnancies. And also, pregnancy itself is a risk factor for domestic violence. But as we all know, that actually outside pregnancy, there has been an increase in domestic violence throughout the pandemic. So this is, so in my mind, I think COVID-19 has highlighted what's always been there, this gender disparity in care. So as I said, intersectionality of disparities. So also other populations such as indigenous population, there are ethnic variations as well, disabilities, geographical living area in the rural areas, they have greater cardiovascular morbidity and mortality and risk factors. Income, lower income have increased cardiovascular risk. Also in women, the traditional cardiovascular risk factors have a greater impact in women. So here just saying that, which I've already mentioned, that women don't tend to present to hospitals as much as men. Therefore, there's a, and also the presentation of cardiovascular disease is often atypical, leading to the diagnosis being under-recognized. So we just need to raise awareness about this. And now moving on to in COVID-19 compared to the general population. And most of them will have no symptoms or mild symptoms. However, if they do get COVID-19, they're more at risk of getting severe disease if they get it after 28 weeks, which is the third trimester. They have a higher risk of admissions to intensive care, a higher risk of premature birth, stillbirth, and preeclampsia. And women who are at higher risk of severe disease basically includes the group with underlying medical conditions, which we talked about, for example, diabetes, obesity, and that is just BMI of 25 or more. So that's a lot of women. And also women who are aged 35 or more. Again, that's quite a lot. And as I already mentioned, those in third trimester are more likely to have severe disease. So here is just a bit of an overview about the maternal risk in pregnancy versus non-pregnant women with COVID-19. As I already mentioned, they're at a higher risk of ICU admission, about twofold. And mechanical ventilation is sort of equivocal at the moment. So these are two different studies. So I've taken this from the RCOG guidelines, which is the Royal College of Obstetricians and Gynecologists in the UK. This guideline was just produced in August. And they have done several versions of this guideline. And initially they did a meta-analysis here using called this PregCo study, and then there have been studies since. So this is just showing that previously they did have a higher risk of mechanical ventilation, but more recently not so much. And then if you meta-analyze these together, then there's no effect. In terms of death, women with COVID, pregnant women with COVID-19 do have a higher risk of death compared with non-pregnant women. As I already mentioned, preterm birth, they have a higher risk of preterm birth, about 1.5-fold. And most of this is due to iatrogenic preterm birth, often done to the delivered baby, so that we can resuscitate the mother more effectively for the respiratory support in COVID, in severe COVID. In terms of stillbirth, there is about 2 to 3-fold risk of stillbirth. This slide is just going back to preterm birth, and as I mentioned, most of them are iatrogenic preterm birth, and this is just to highlight that there is this disparity in ethnicity. Now, this is quite a recent study, just published last month in Lancet Regional Health, a retrospective database study, and it basically showed that American Indians and Alaskan Natives have a 3-fold risk of preterm birth compare, and then that's in comparison to the rest who are sort of just over 1.3, 1.4 fold. So pretty much double the risk compared to the rest of having preterm birth. And this slide is about preeclampsia, which obviously we are all very interested in. And this is just saying that actually COVID-19 is associated with preeclampsia. This is a meta-analysis of 28 studies that's currently in press in American Journal of Obs and Gynae, and it showed that there is a 1.6-fold increased risk of preeclampsia. And here is just to remind me to mention that, of course, in preeclampsia, women are put on aspirin for preeclampsia prophylaxis, but COVID-19 can be associated with thrombocytopenia. So when aspirin has been prescribed for the prophylaxis of preeclampsia, we should stop this for the duration of the infection so that we don't increase the risk of bleeding in those women with thrombocytopenia. Okay, so now we're moving on to treatment and anticoagulation. So again, this is, I quite like this sort of schematic showing a spectrum of severity. So you have outpatients or inpatients or in the patients in the ICU. And in terms of the COVID-19 phase, you have the viral phase here, where most people are the mild spectrum. But then when you get into the hospital, this is the inflammatory phase, which we talked about earlier, causing severe disease. And that's why there are different types of treatment targeting different phases of COVID-19. So I will go into them separately in a little while, so this is just an overview. So for the mild part, we can use monoclonal antibodies. And then once people are in the hospital, we can use antiviral agents such as remdesivir. Moving on to slightly more severe illness, then people would be put on corticosteroids such as dexamethasone. And then further down the line, we'd be thinking about treating them with tocilizumab, which is an anti-IL-6 monoclonal antibody. I'll talk about anticoagulation as a separate topic at the end. So this is really just to say that, just talk about the different therapy. So remdesivir, this is a meta-analysis looking at remdesivir, and actually it shows that there's no advantage in survival, but it does have advantage in other non-survival factors, outcomes such as a proportion receiving ventilation or ECMO follow-up. In the large recovery trial, they looked at dexamethasone and tocilizumab in different stages of the disease, and it showed that there is a mortality benefit for dexamethasone compared with usual care, and also they showed that for tocilizumab there is a mortality benefit as well. They've actually meta-analyzed their results, which is here, and then added that to all the other trials, and it does show a definite benefit. So baricitinib is a JAK1 and 2 inhibitor that's also being studied. And in this retrospective study, looking at baricitinib, which reduces cytokine such as interleukin 2, 6, and 10, and interferon gamma, looking at the survival benefits of baricitinib plus dexamethasone versus dexamethasone monotherapy, it does show that there is some benefit. However, as I said, this is a retrospective study and is relatively new, so we're awaiting more research on this. Monoclonal antibodies, such as Regencov, as I mentioned earlier, it is mainly used for the early part of the disease, and the indications are mainly for non-hospitalized patients or those who are hospitalized for diagnosis other than COVID-19. So those with mild to moderate disease with a lab confirmed infection, but those who are at a high risk of progressing to severe disease and or hospitalization. So that's current indication, but a recent study, again published sometime in July or August, just shows that actually when you use the Regencov, there is a benefit in terms of preventing infection in those previously uninfected household contacts of infected individuals. So now that sort of brings in the question that perhaps we can use it as a post-exposure prophylaxis for high-risk individuals who are not fully vaccinated or who are immunocompromised. So you can see here Regencov compared to placebo. So duration of, and even if they did get infected, the duration of the symptomatic infection is shorter. Yeah, mean duration shorter, and then yeah, symptoms are still, again, this is all about the duration, and the high viral load, again, much lower. So this is an example of one of the guidelines from NIH. So of course, each country has different guidelines, but this just sort of brings in what I already talked about at the beginning with that schematic. So just saying that for the milder spectrum, they would recommend against the use of dexamethasone. For those requiring supplemental oxygen, they recommend either remdesivir, dexamethasone plus remdesivir, or dexamethasone. And towards the more severe end, then it's dexamethasone or dexamethasone plus remdesivir, and adding either baricitinib or tocilizumab. And then the most recent update last week said that we can also add in sarilumab as well. And for the very unwell patients who are ventilated or on ECMO, you can of course use the dexamethasone, but also for those who are within the 24 hours of admission, i.e. the earlier phase, you can also add tocilizumab as well, or sarilumab if tocilizumab is not available. Moving on to pregnancy considerations, as I said earlier, if the woman is in third trimester, then we will need to think about delivering the baby, but of course, in an MDT setting with other specialists, intensivists.
I think Dr. Wu's presentation froze. We might just give her a second and see if she can come back in.
Oh. So slightly different regimen to what we normally use for fetal lung maturation. And then we will use it for 10 days or up to discharge.
Doctor, we can't see your slides anymore.
Oh. Oh. Can you hear me?
Yes, I can hear you well.
Oh,
yes.
okay, fine. Right, sorry, let's just try again. So is that any better?
Yes, I can see your slides again. I'm
okay,
so sorry.
Sorry, yeah, my internet is a bit dodgy sometimes. So right, so we're here.
Perfect, thank you.
Okay, yeah, pregnancy complications. Yeah, so I was just saying, I don't know why this is not minimizing. Yeah, so I was just saying that, yeah, so tocilizumab can be used in pregnancy as well in hospitalized patients with hypoxia and systemic inflammation. But for remdesivir, not so much, and is only considered for those not improving or deteriorating. And in the most recent update of the guideline last week, the RCOG guideline have said that we can consider the use of Regin-CoV monoclonal antibodies in those without any SARS-CoV-2 antibodies. Now moving on to anticoagulation and thromboembolism risk. So as we all know, that COVID-19 can lead to increased risk of thromboembolism. So both in terms of the venous and the arterial. But it is still unknown what is the best anticoagulation treatment, and there's no consensus. As you can see, that there are lots of different trials ongoing, with some using heparin-based regimens, some with fibrinolytic therapy, direct oral anticoagulant, aspirin, or other antiplatelet agents, and being used in different types of settings. So at the moment, we still don't know. So this is for the general population, just to clarify. But in women, it is quite clear. So just outside pregnancy, we would recommend avoiding combined oral contraceptives and estrogen replacement therapy in COVID-19 positive women in order to prevent venous thromboembolism. And within the pregnancy, it is recommended that for all those who are hospitalized with either confirmed or suspected COVID-19, we should offer them prophylactic low molecular weight heparin, unless there's some bleeding risk or unless we're expecting birth within 12 hours. Of course, it might be that the dose needs to be changed if they have severe complications such as thrombocytopenia. So for all women who are pregnant or within that 6-week postpartum period who have been hospitalized and had COVID-19, they should also be offered thromboprophylaxis for 10 days upon discharge. And of course, again, individualized for those with persistent mobility, you might want to give them a longer dose, longer course. Vaccination. This is just to say that COVID-19 mRNA vaccination has been linked with myocarditis, but actually mainly in young men, so not specific to our population. So that, I suppose that's good news for in our population of interest. And you can see that there's almost a 10-fold difference. So this is, but again, the absolute rate is very low. So for example, in the young men, so you have 62 cases per 1 million dose of COVID vaccine doses. And then of course, the risk and benefits after the second dose, you can see here, actually, the cases are so low, but the benefit even in the younger men and women. You're preventing a lot of COVID-19 associated hospitalization. So we would still recommend giving vaccines. This is really just to show that it is on the increase the myocarditis and pericarditis after the vaccinations have started. Just briefly talk about vaccine-induced thrombosis and thrombocytopenia. This is mainly linked to the AstraZeneca and Johnson & Johnson vaccines. The incidence is very low, 4 per million in the UK, but higher in Europe and Australia. So again, mainly in the younger population, less than 50 years old, and estimated to have 3.1 cases per 100,000 doses given. So it's a idiopathic reaction, so not actually associated with the usual venous thromboembolism risk factors. And so pregnant and postpartum women are not at higher risk of vaccine-induced thrombosis and thrombocytopenia. Now, just moving on to pregnancy and vaccination, of course, it is strongly recommended, and that's simply because of the risk of severe disease for those who are not vaccinated, especially in the third trimester. So vaccines can be given at any time in pregnancy, as well as for women who are breastfeeding. And actually, there are more than 200,000 women who have had COVID-19 vaccines with no concerning safety signals. And the phase 2 safety data from Pfizer is expected soon. It was expected last month, but it's not out yet. So as I already said, 98% of women admitted to hospital with severe infection have not had a vaccine. And that's why we strongly recommend this in pregnancy. And we would prefer to give them Pfizer, biotech, or Moderna vaccines. Just in terms of the antibodies, COVID-19 antibodies have been found in umbilical cord blood in the vaccinated woman, as well as in breast milk for 6 weeks after the first dose. So there can be some protection for the baby. So finally, health disparities. I don't think I've got time to talk about the post-COVID, so I'm just going to end on this slide. So this is really just to bring it all into context that women are a vulnerable population, but there are other vulnerable populations as well, such as racial ethnic minorities and those from low socioeconomic backgrounds. And they do tend to have poor cardiovascular outcomes related to COVID-19. And there are challenges for the testing itself in terms of accessibility, outreach, etc., and the digital divide, and also in terms of the COVID-19 clinical trials. The vulnerable groups are not very well represented, and also there's a lack of principal PIs from underrepresented populations as well. So it's important for us to try and raise awareness for patients and clinicians as well about the increased risk for the vulnerable population. And for women, we can try and do clinical monitoring with telehealth and remote patient monitoring in terms of monitoring the hypertension postpartum, for example, and the home monitoring, as Lucy said, has been very successful in some trials. So thank you very much for your attention, and I look forward to your questions.
Right. Thank you so much, Lindsay, for your clear talk. So we have time for 1 or 2 questions, and then Dr. Marquez, that she joined us, will close the seminar session. So please feel free to do 1 or 2 questions. All right.
It's fine. I don't mind.
There's no question. Okay. Okay, Dr. Marquez.
Thank you so much. So good evening from Australia. I'm Associate Professor Francine Marquez from Monash University, and on behalf of the International Society of Hypertension and the Mentoring and Training Committee, which I chair, I'd like to thank all the speakers for their outstanding presentations. Also, Dr. Pansy Wu and Dr. Rodrigo Maragnon for chairing, and also Dr. Maragnon for organizing this outstanding training session. I enjoyed very much all the talks, and I learned a lot about several aspects of how sex affects mechanisms, also prevalence and treatment of hypertension, as well as the impacted risks of complications during pregnancy and specific issues that women face living through the pandemic. So the video recording will be made available by the Society soon. But I really appreciate everybody that has made an effort to attend the session and also participate and ask questions. And we look forward to seeing you in our next event, probably in the next 6 months. But yeah, thank you so much again.